Okay, thank you. We ready? Okay, Dr. Calamere, 5 seconds after we can start. For the court reporter, we have Dr. Calamere, Fineski Peña-Mora, Jose Pagan, Sally Hernandez Pinheiro, Barbara Lowe, and Scott French. Dr. Katz is also here. Those are the board members and should be reflected accurately in the transcript, okay? Dr. Calamere, 5 seconds after the recording, you can start.
All right, thank you so much, Calicia. Welcome everyone this morning. Apologies for our little technical glitches. I have to say, on the average, we've done so well with this. We have to have some glitch hit at some point. So, but anyway, I'm glad we're starting. This is a joint meeting of the MDPA as well as the Information Technology Committee. As Calicia mentioned, Scott French will be here as a full voting member representing Stephen Banks. So if I can, let me start with the MDPA minutes, and then I'll turn over to Vinyasky for the IT minutes. So for MDPA, hopefully you've read the minutes. Does anyone have any questions or issues or need for adjustment? Okay, so could I motion then to accept the minutes?
Move to accept.
Excellent. Anyone opposed to the minutes or any issues with the minutes? All right, hearing none, minutes do pass. And Vinyasky, if you want to go to the IT minutes. I think you're on mute.
Thank you, Dr. Calamia, and good morning, everyone. I would like to propose a motion to adopt the minutes of the IT committee meeting held on February 9th, 2021. Anybody has any questions about the minutes? If not, if there is no question, everyone in favor?
Yes.
Yes.
Aye.
Anyone opposed? Hearing none, the minutes are adopted. Back to you, Dr. Calamia.
Thank you. We'll move on then to our Chief Nurse Executive Report, Dr. Sineas. You can give some highlights, that would be great.
Thank you. Good morning. So for our nursing highlights for the system, we successfully deployed over 1,694 nurses for COVID-19 Wave 2. We've also done a lot of work around nursing education, around our vaccine program. We've also brought on 134 vaccine nurses and partnered with CUNY with bringing on 1,000 students to help us with our vaccine program. We also partnered with CUNY for 5 community grants. I must say, since writing up this report, we've successfully been awarded an additional grant. So we have 6 community grants to really help us with cancer prevention for our patients and also education, patient education. Also, April is Safe Patient Handling Awareness Month. We will be hosting our first virtual system-wide Safe Patient Handling Awareness event. We are also in the process of wrapping up our clinical ladder this year. 2,062 nurses applied to our clinical ladder program, which is a significant increase from last year. That is part of our NISNA agreement. And so we're very pleased with the amount of nurses who are really dedicated to professional development. We've also recently launched a nursing eye care module. We will begin purposeful hourly rounding simulation this month, which is evidence-based to improve our care experience scores. We also have recently graduated our 5th cohort of the nurse residency program. We're very proud of our 91% retention rate of our nurse residents from 46% 2 years ago. We've also recently started the NP fellowship program with the Weizmann Institute as of April 1st, 2021. And just 2 more events. We recently hosted a certification event in March of 29th of 2021, where we had 275 nurses across the system attend. I'm very proud of all of the nurses who would like to take advantage of our certification differential. Last but not least, today we will be hosting our 2nd education fair. It will be virtual with CUNY, where we have over 200 nurses who will take part in understanding the different programs for education within CUNY to create educational pathways for our nurses. And so we're very pleased of the attendance registrants so far. Thank you so much. That is my report.
Super. Any questions at all for the nursing report from Dr. Sneas? Okay, then we'll move on. Lisa, I'm guessing that we now have the Chief Medical Officer report ready? Can we do that now
Yes,
or no?
Dr. Calamere, we ready.
Okay, so our Chief Medical Officer report, Dr. Allen.
Thank you, Dr. Calamia. Good morning to the members of the board who are present. I've submitted to you a summary of all of our accomplishments for 2020. They include services that fall under MMPA, such as laboratory, radiology, the sim lab, women's health. We have clinical services lines, including critical care, nephrology, and behavioral health. We also are responsible for credentialing, occupational health, and research administration. Rather than going through all of our accomplishments, I'd like to focus on 3 areas. One is laboratory, just briefly. In addition, women's health, and lastly, the dental services. I just want to mention to the board that Kenra Ford, our Vice President of Clinical Operations and Laboratory Services, has set up a process in the lab for surveilling for new mutations of the COVID-19 virus. I don't know if Kenra would want to say a couple of sentences or if you have any questions for Kenra about what we're finding and what she's doing.
Good morning, everyone. Just really briefly, we're going into about week 3.5 of for COVID-19. We have a very diverse team working on this. Our system level ID docs, a data analytics team, and as a system, we are reviewing weekly. As of last week, we have submitted close to 1,000 samples. This program is for all of our admitted ED patients. As you know, we're already participating in the city surveillance through our samples going to Pearl Laboratory. The Pandemic Response Laboratory, Pearl, is performing the gene sequencing, and we will continue to ramp up as capacity allows. Answer any questions?
And I do want to highlight throughout the year 2020, if we recall,
Excuse
testing.
me, who's speaking?
This is Dr. Michelle Allen.
Okay, can you start over, Dr. Allen?
I would like to say over the course of the year 2020 through our pandemic, if you remember, we were originally sending our specimens to the city lab, then to the state lab, and then to Atlanta, Georgia. Kenra Ford was responsible for bringing all of that processes into our house. Collaborating with Northwell initially in commercial labs so that we are now doing those tests ourselves to the point now we are testing for mutations. I just want to highlight that we would never be where we are today without the support of our laboratory services.
Thank you, Dr. Allen.
Yeah, certainly kudos. The lab has been tremendous, and it's been a huge help, obviously, to getting a better understanding of what's happening. Just one quick question. I'm just curious. I mean, do we get our results sort of real time, and do we have any sense of how that information ends up impacting? As far as I guess, apparently, perhaps the UK variant has greater transmissibility and virulence. Does that have any impact? Do we know certain areas where it may be more prevalent, where we're maybe putting more attention to vaccines and so on, and education? Just curious if we're using the data, I guess is the question.
Really good question, Dr. Calamia, and thank you. So the actual turnaround time, as we all know, this is intensive testing. So it's about between 3 and 4 days. We're doing everything possible to shave off hours in the overall turnaround time. But I would say by the time the testing is completed and we have transformed the data into something informative, it's at about 5 days. As it relates to have we identified anything differently than we have at the city level, the answer is no. And we're currently working on overlaying with our vaccination information so that we can start to focus where appropriate.
Thank you for that. Any other questions? Otherwise, I'll turn back to Dr. Allen. Okay, Michelle.
Thank you, Dr. Calamia. I've asked Dr. Wendy Wilcox, who's the co-chair of our Women's Health Council and who's the Chief of Service of Obstetrics at Kings County Hospital, to share with us what we're doing about maternal mortality and morbidity. As you know, there's been a lot of emphasis on that and the racial disparity in our maternal mortality rates. We've established a maternal medical home. So Dr. Wilcox, can you share with us briefly what's been going on?
Thank you, Dr. Allen. Good morning, everyone. The maternal medical home is really centered on caring for our patients who are outside of the hospital. It's based on the primary care patient-centered medical home. It really combines two thought models. One is socio-ecological, which is based on building trust and lasting relationships between patients and their healthcare team, and the socio-cultural environmental model, which really focuses on making sure that patients are connected with the resources and services that they need. Next slide, please.
Next slide.
Great,
Thanks.
thank you. So patients typically are tiered by their amount of risk, and these are pregnant patients, and those who are Tier 3 criteria are really eligible and need the highest risk comprehensive services. As you can see, there are different ways that one can be categorized into a Tier 3. Certainly some of those are medical conditions and diagnoses or comorbidities, and some of them are psychosocial, like depression, history of domestic or current history of domestic violence, substance use, and needing financial and housing. Of note, about 36% of the patients we see for prenatal care meet Tier 3 criteria. Next slide, please. In 2020, our maternal medical home coordinators and supervisors, which are social workers, placed over 2,700 referrals for our patients. For medical support, the bulk of those were nutrition and dental services. And for psychosocial support, the bulk of those were for mental health and also WIC benefits. Next, please. Switching gears, we're going to talk about simulation labs. And simulation is geared to help our providers care for patients who are in the hospital. I'm sorry, yes?
Could we take questions on the medical home first? Hello?
Sure.
Oh,
I can hear you.
I just, on your Tier 3, would you have found that most of our patients were referred because of psychosocial or medical or a combination?
A lot of them have a combination of all three. It could be either or. Our patients are screened. That slide wasn't included, but we use a variety of screening tools, multiple screening tools, and also provider referrals. A lot of our maternal medical home coordinators work with our high-risk obstetrical services, definitely to capture those patients who have the clinical diagnoses, but then also we have an expanded screening program so they can also catch the psychosocial diagnoses. I don't have that number.
No, it's fine. I was just
Thank
curious. And your 39% dental referrals, as I understand it, we typically want all of our pregnant patients to have dental care. Are these referrals, so I would have thought, are these referrals from dentists or primary care physicians?
These are referrals from our obstetricians and other providers of prenatal care. And we typically ask a patient if she has dental care elsewhere. Some of our patients do. They have their own dentist. And so this number may reflect patients who did not necessarily need it within our system.
Okay, thank you.
You're welcome. As I said, simulation focuses on helping our providers take care of patients when they're in the hospital. From June of 2018 to December of 2019, as you can see, there was a huge cadence of simulation events. These mainly focused on skill labs to estimate blood loss, as well as OB life support, simulation drills to save the life of a mother if she has a cardiac arrest during labor while she's pregnant, we'll say. Unfortunately, that cadence fell off due to COVID. However, we were still able to hold some events. We are now focusing on having most of our providers trained in the newer version of the obstetric hemorrhage course, and certainly we're going to roll out the severe hypertension and pregnancy simulation course probably by in the fall. Next slide, please. The OB life support that I just mentioned actually has saved the lives of 3 of our rapidly deteriorating mothers. These mothers came in and they were having, cardiac events. And due to the simulation training, the team went into gear right away. They started compressions. They got the mother delivered. And really called our critical care teams to help assist with her cardiac status. And all 3 mothers returned home a few days later with their healthy babies. So that is a great story.
Great.
Thank you. And these are the number of completed in situ simulations in 2020. The bulk was in OB life support, as you can see, but also our skill stations and our postpartum hemorrhage, and certainly in 2021, we're going to continue our focus on hemorrhage and move into eclampsia. Next slide, please. And I believe that's it. Thank you.
Yeah. So are there any questions? We have a few minutes left, which I actually wanted to devote to the dental services, as members of the board have expressed a very particular interest in the preventive dental services we are offering. Are there any questions for Dr. Wilcox?
Just a quick comment, because obviously this is a huge national issue and has multiple components, including many social determinant components. But the work you're doing is superb. And I guess my question is, or comment is, hopefully we can perhaps bring some of this to the literature, because it's clear to me we're doing some cutting edge and hopefully best type of activity here. So if we could share it, I guess, for best practices, I think that would be a superb thing. So just a comment on that. And then any other questions, a great program, and certainly it's great work being done.
Thank you. Is Dr. Badner on the line?
Yes, I am. Good morning, and thank you very much for your interest in oral health and the opportunity to present the oral health program that we have at H&H. When Dr. Katz first came here, he identified that he didn't actually know that much about oral health, and we made it a charge to put together a response that would allow us to reflect, in fact, what the program is throughout H&H. And the slides that I have for you summarize our program, both the strengths of it as well as the opportunities for improvement. We have 18 facilities. We got a survey responses from 16 of our facilities, and all of the acute care facilities were included, including most of the Gotham sites, including some of the new centers of excellence sites. In the dental world, the places where we do our treatment are called operatories, and we have approximately 200 operatories or places where clinical care can be delivered, as well as 20 ambulatory surgery areas in the clinics. So these are AmSurg units that actually provide general anesthesia within the dental facilities that allow us to do what you would be familiar with, wisdom tooth extractions primarily, but also dental implants and treatment of patients who need sedation. That includes children as well as those with developmental disabilities. In addition to the operatories and the ambulatory surgery areas in our clinics, we use operating room block time for major dental surgery cases, including pathology, trauma, reconstruction, in all areas of dentistry, and also allowing us to serve those with IDD that can't be handled in our clinics. From a physical point of view, or physical plant point of view, we have lots of high-end equipment, including panoramic radiography, head and neck cone beams. We have laser surgery units, microscopes, intraoral scanners, which allow us to sort of do the highest cutting-edge technological dental services that can be found. Some report in our review of the survey, some report that their clinical space is excellent and new, but most of the facilities have identified that there has been no renovation, no capital improvement in the last 10 years, except for maybe Kings County, which had a new dental facility, and there's tremendous variation in the physical state in the clinics. Next slide. With respect to our visit data, depending on what year you pick and the activity, we're somewhere in the neighborhood of 280, 310 visits per year for outpatient dental services. But COVID obviously hit us very hard. The governor shut down all dental facilities except for emergency care during the month, in the middle of March through the beginning of June. And that actually reduced our volume tremendously for fiscal year 2020. Our volume is returning, but it's about 15% below previous volume, but moving upward. The way we distribute our services is that about 55% of them are general dentistry, and the remaining 45% of that, 35% is split between pediatric and oral and maxillofacial surgery. We do lots of sedations or general anesthetics in our clinic and admit approximately 1,000 patients per year. And we provide coverage in our level 1 trauma centers alongside the departments of divisions of plastics and otolaryngology for the maxillofacial trauma, which means that they are the first recipients of the patient as they come in with any maxillofacial trauma that has occurred from a car accident, an assault, or any other injury that might occur. Next slide, please. Next slide, there you go. In terms of clinical hours and staff, all of our ambulatory clinics are open the standard 5-day, 40-hour week. 6 of the facilities have availability on Saturday. 1, Woodhull, actually has availability on Sunday, and 5 were doing evening hours. We've struggled this past year with evening hours, partly because of the staffing, but we have approximately 100 FTE attendings. Our care is generally delivered by dental residents. The dental residents include general practice residents, pediatric residents, and oral and maxillofacial surgery residents, with about 200 dental residents all told. In addition, there are 220 ancillary support staff employees. Those are the dental assistants, and dental hygienists number approximately 20. And that is the complement of personnel. When I've said that we have been struggling with some of the physical plant issues, we're also struggling with respect to staffing when it comes to expanding hours. Next slide, please. We have had some tremendous successes, and we're very proud of many of the things that we've been doing, including multiple very departmental collaborations with the Department of Pediatrics, Medicine, Women's Health, Surgery, and Anesthesia. In anesthesia in particular, here at Jacobi, we have a dental anesthesia residency program, and we are the anesthesia residents for the entire service, or for the entire hospital. And these dental anesthesia residents were incredibly useful during the height of COVID, as they were employed providing airway management for patients who were intubated with COVID, and really demonstrated their skill and participated fully during the times we were shut down. We've had lots of interprofessional education. That is, in fact, one of the things that we're very proud of. The medical acronym for the head and neck exam, which left out the O, which is the head, ears, eyes, nose, and throat. We've added the O so that the physician should look at the mouth as well as everything else in the head and neck. And we actually did a training with the Albert Einstein College of Medicine, teaching their medical students to include the O. One of the big opportunities for improvement should occur in hopefully fiscal year 2022. We're in transition now in 2021, is that we are on a separate electronic dental record called Dentrix from Epic. The Epic program does have a dental module, which was inferior at the when Epic was being chosen for the medical side. And based on the last 4 years, there have been improvements, and the dental council has passed a resolution to move to Epic Wisdom as soon as it complies with a couple of things that need to still be improved. And that is hopefully going to be finalized this coming council meeting in April. We've also had improvement with dental revenue cycle integration, in which we've gotten financial managers to work on the dental billing component, which has been a struggle here at H&H because dental billing is so different from medical billing. And Joint Commission has suggested and made it clear that sterilization of dental instruments should be centralized, and we've been working very hard to do that throughout the facilities. In addition, we do quality improvement around fluoride, sealants, and dental opioid prescription reductions, because dentists are the were the number one prescribers of opioids to adolescents, and there's been a real initiative through education and virtual training and grants that we receive to reduce opioid prescribing by dentists for dental procedures. Next slide. We have lots of different initiatives that we are proud of. We have started to embed dental providers in pediatric clinics. We've gotten grants from HRSA and other foundations to do this kind of work, where we can put a dental provider, possibly a dental hygienist, in the pediatric clinic, where they can provide prevention, education, as well as fluoride varnish to the pediatric population. And when they triage patients who are of unique need, can be immediately brought into the dental facility. We're also working on the same kind of thing for pregnant women in the Women's Health Center. We had a previous HRSA grant focused on pediatrics clinics. This new grant that we've gotten here at Jacobi is a 5-year grant, which is talking about bringing dentistry outside of the dental facility into women's health and medical clinics, particularly around diabetes patients who are at higher risk for inflammatory oral health conditions, and the inflammatory oral health conditions affect the diabetes. And we're working with women's health clinics to do the model that we did in pediatrics in women's health. Alongside those initiatives, we've done a whole lot of work around HIV-infected patients, developmental disabilities. We received recently a grant to improve the triage of the patients with developmental disabilities with teledentistry. No, we're not doing fillings with a camera, but we are able to properly triage patients as to whether or not they need to be taken from group homes into the OR to be examined, or whether or not they can be managed locally in their facility. That's really a big step forward, and we have working with companies that have created intraoral dental cameras that can facilitate this activity. We believe in the opportunity to educate and provide clinical care, but also to publish and do research, and we've done a bunch of research and publications around the relationship of oral health to general health, reducing the non-traumatic dental visits to the emergency department, so patients who come to the emergency department with a toothache or an abscess really should be taken care of by their primary care dentist, but access to care is really one of the biggest concerns. We also have an accredited craniofacial center. So it's called the Quad C, the Congenital Craniofacial Care Center, and they're taking care of patients that are born with congenital anomalies, and most likely cleft lip and palate, that can be managed in an interdisciplinary way, including not just the surgical side, but the speech pathology, nutrition, nursing, all of those conditions that would necessarily be needed to provide that service. And we're actually marketing this craniofacial center to actually be able to provide this kind of service for all of the patients that are seen in H&H. And we're working with that. Our leader in that is actually working at Jacobi, NCB, Harlem, and Met already, and is using that opportunity to triage patients around the system to the craniofacial center where appropriate. Next slide. I think that may be it. Yeah, right, that's it. So we have tremendous demand for our services. It is very difficult to accommodate that because of how many patients need our services, and the motto that we have at H&H, which is to take care of people regardless of their ability to pay, really does drive patients to us. As Dr. Wilcox said, 39% of their referrals are dental, and the biggest hurdle is being able to get an appointment. We are booked. We are trying to complete care, not just see patients for screening and then not be able to provide the care, but we struggle with capacity issues both on the physical plans as well as the staffing to expand the hours to incorporate more access, because anything we build will be full immediately as we open it, whether it be in hours or in physical plant. It's really a robust service that we're very proud of, but it has tremendous opportunities for growth and improvement. And while we're doing a lot, we could do a whole lot more. Thank you for the opportunity to speak. I hope that gives you an overview, and I'll answer any questions anybody has.
Thank you very much,
I'd
Dr.
like to-
Badner.
Questions? Sorry.
After,
below on the line. I would like to say that the work is tremendous. I'm particularly happy to hear that the focus on opiate prescriptions for adolescents are being addressed. It's very important. It has been under discussed in many forums. So thank you so much.
Dr. Badner, first, I want to thank you for this comprehensive report. This area is of such critical importance to the hospital, to myself, to my fellow committee members. And I think as comprehensive as this is, we need an even more forensic analysis of what we do, where we do it, how we do it, the kind of equipment we have, the type of needs we have, and even more broadly speaking, you know, should we be in this space? How should we be in this space? Looking at cost benefit. I mean, these are questions I'm sure you've looked at over time. So for now, I'm just going to ask two questions because I know we're going to have follow-up sessions. But my first question is, you noted that 35% of the visits are split between pediatric and OMS. And I'm wondering, would that 17.5% of pediatrics, what percentage of our total patient population are pediatric patients?
In the dental facilities?
Well, I would ask, well, yes, in the facilities, and if you know overall.
Yeah, so pediatric dental services are available in each of the acute care facilities, but only a few of them, not all of them, have pediatric residency programs and have pediatric specialists available to provide that service. And that is actually where there is an opportunity for growth. The fact of the matter is, where there is a pediatric residency that is occupying some of the operatories, you're delivering much more pediatric care, both in the dental facility as well as the outreach to the pediatric programs that is in the medical side. Because what happens is when you can integrate the pediatric residents of dental with the pediatric residents or the facility at the pediatric medical clinic, you're going to get much better integration and much better service, even for visits that don't necessarily count in what I'm describing, but in fact are part of what the health of the child. It's in the facilities that have no pediatric program per se where you get the differential in the number of visits. For example, at Jacobi, we have a pediatric residency program, so we're about a third of our visits are pediatrics, whereas some of the places that don't have that, it's much lower, and the average is about, as I said, about 17.5%. But the fact is, wherever there's more pediatric residency and more programs, there's more visits. Because again, whatever you build is full, and all the others are full.
Yeah, two things drive my concern and our concern, I imagine. One is that just kind of the shame and embarrassment and lower self-esteem young people have when they don't have good dental care. And two, I know that for the homeless, the most frequent reason they don't get a job is because of really poor dental condition of their teeth. So they're really and not to mention the maternal issues, which were described earlier. So I really look forward to having an ongoing discussion about this. Thank you very much, Mr. Chairman.
You're welcome. Thank you for your interest.
Thank you.
Fanny, did you have a question?
Yes, thank you, Dr. Calamia. Dr. Badner, again, thank you for the presentation. Very illustrative and informative. I really appreciate it. I just have a couple of questions. One is, if we move to the next slide where we talk about the clinics, are we also pouring in the dental services in the Gotham clinics, or is that mostly the one runs by Health and Hospital directly?
The Gotham, we're working, you know, I'm trying to figure out a way to get Gotham sites more integrated. Many of the Gotham sites do have dental clinics, but there are Gotham sites that don't have dental facilities. The new centers of excellence, the one in Queens and the one in the Bronx, they do have them. It's my understanding. I know the one in the Bronx does because I've spoken to them about it. And I believe that the other two do as well. It's the older ones that do not. I can give you the list of the older ones that do not have dental facilities at all. They're not providing any dental care at all. But the Morrisania, Renaissance, East New York, many of them do have dental facilities.
And there is, and like you mentioned, you're trying to integrate them. Is there a plan as you expand to bring them, because they are in the neighborhoods and people come there for other services? So it's a really good point of service if you want to think about it.
Right. So the Dental Council includes all of the places where there is a dental program included. So the Gotham sites are included in the Dental Council, or invited to the Dental Council. The Gotham sites that don't have a dental facility have not been invited to the council, but it might be a corporate decision about what do we do with those sites that do not currently provide dental, and how do we get them to provide dental services. There are ways to do it mobile. There are ways of doing it with a reduced infrastructure, et cetera. But the fact is, right now, they're not providing dental services, as far as I know, at all, and there are at least a half a dozen of them that don't do that.
Thank you. And the second question is that one of the issues, and again, Sally, Jose, and Frida and I have visited a lot of different pre-COVID hospitals and clinics, and oral care is something that also we always ask questions, and we were introduced to the facilities. But we also heard for other specialty, the delay on the time for having a specialized care. You know, the time from when your general physician said you need this specialized care, how long it takes to get the appointment. For the clinic and the oral care, do you have an idea of the average wait for a special care for patients?
So before I answer your question, I do want to make one comment that I think I didn't say, which is H&H did an unbelievably good job at investing in infection prevention during COVID to protect the patient as well as the healthcare personnel to feel secure and safe. Remarkable investments in infrastructure with suction devices and HEPA filters and extraoral suction and extraordinary. We would not be functional without that. So that investment really helped to make it work. To answer your other question, it's a little embarrassing because to get specialized care, meaning the care that you need, that you should have because that's what anybody would expect. Someone who can't get dentures but needs implants in order to get a denture. And we actually were quite effective in helping Medicaid cover implants for medically necessary treatment. So that was an initiative that we participated in to change the Medicaid guidelines. But to get that care that's specialized can be a very long wait. There's no question routine care is easier to deliver. Specialized care is not available at all facilities. And while surgery, which is the extraction of teeth, may be available, the placement of teeth or the replacement of teeth is harder to get, and root canal therapy is harder to achieve. And I actually was told not to actually say the actual amount of time it takes because it's too embarrassing. But the fact is, we do our best with it is a really long wait.
I think this is, and the reason I asked the question is because as Sally was mentioning, you know, we really had those visits, and it was wonderful to see the investment, as you said, that Health and Hospital has made. But we also understand that, you know, specialized care is very needed care, and that wait can affect people's life considerably. So I hope that you have that into consideration in whatever new phase you're planning for oral care, because as Sally mentioned, it does affect, your ability because of the perception that people have to get jobs and your self-esteem and all that. So I hope that you consider as you are planning your next phase. Thank you.
Two comments: kids lose more days of school from dental problems than they do from asthma. So if we all know asthma, but dental problems are actually keeping them out of school more. And we absolutely know that without dentures and without teeth, you're not going to be employed. So one of our big efforts is to try to make sure they can get a prosthesis so that they can actually function daily living and be out in the real world. The only benefit of COVID that I can see is that you wear a mask so people can't tell you don't have teeth. But that's not something that I'm proud of.
Well, hopefully that will be short-lived, I'm hoping. But I apologize for cutting you off.
Thank you.
This is clearly, an area, as Sally said, this is the beginning, I think, of making this much more. It's a very important issue for the board. You've made it clear. We really do have access issues. We do have, the issues, I think, that we're going to be needing to put plans together. And I'd like to ask Dr. Allen, Dr. Katz, to make sure we continue to top and maybe come up with some concepts about how we can expand access and so on. So thank you again. I think it was very merited. We needed this amount of time for this. Having said that, I'm going to have to ask the following presentations to be as brief as possible because we really are, I think, running against the time issue. But Dr. Badner, thank you so much. I think it's really enlightening.
Thank you all for your interest and time.
Thank you.
Thank you. And I'm going to now move on actually to Metro Plus. And again, I apologize, but try to make sure we truncate these next presentations as best we can. So on to Dr. Shah.
Yes, good morning, everyone. So there'll be 4 brief highlights on the regulatory side. To note the disenrollment moratorium for Medicaid CHIP. The essential plan is now continued through June 2021. Secondly, open enrollment itself has been extended through the end of the year. The cost-sharing bands have already been updated from your presentation, have now been extended for telemedicine and COVID testing to May 4th of this year. And lastly, the American Rescue Plan Act should, if implemented appropriately, expand health coverage for many New Yorkers. One example that's cited in your presentation is that the available tax credits for individuals getting their health insurance through New York State exchange products or qualified health plans has now been extended to people earning up to 400% of the federal poverty level. That program starts April, so it's already started through the end of this year. The next thing I'd like to just mention briefly is the Special Investigations Unit. MetroPlus has revamped its unit. Its goals are to mitigate and report suspected fraud, waste, and abuse to regulatory agencies and recover funds for the plan. Since 2019, when the unit was revamped, the SIU has achieved cost savings of over $2.5 million and has obtained many settlement agreements. The major mechanism by which this is done is through data mining using both internal analytic resources as well as proprietary software that identifies outlier providers through peer-to-peer comparisons. And although the plan mostly focuses on overutilization of services inconsistent with the medical needs of impacted members, the committee should note that we also focus on underutilization of services, in particular with capitated providers, to ensure that their attributed members are in receipt of appropriate services through their care, including preventive care. Last couple of points, the MetroPlus app launch occurred. We have a provider portal and a member portal that people can access through the internet, but this is a mechanism that they can access it through their phone. It's an app that's available through both through Google and the Apple App Store, and will hopefully continue the plan's focus on improving the customer experience. And lastly, in terms of the mentorship program, the committee may know that we launched a program to really generate and develop the next generation of leaders, both develop their professional talent as well as retain it. And 24 mentors were paired with 31 mentees. This was a highly successful program, launched last fall, is actually completing formally this month. And the success of that program has meant that we're actually launching a second cohort of mentees starting in June that will also occur through an application process. Thank you.
Thank you again so much. Any questions or comments? All right, and again, I think, superb, and I'm very happy to hear, as you mentioned, about monitoring overutilization and underutilization as well. So that's really important and helpful to know. All right, if we can move on then, Dr. Mendez, on the information technology update.
Thank you very much. And David, if you could just go to slide 4, we'll focus on that. I'll just give a brief overview. It'll be the biometrics integration slide, if that's not, thank you. I have submitted a summary for the first quarter calendar year 2021 of IT update, and the components of that you'll see as you read the report are the EITS goals for 2021, the strategic dashboard metrics, and how they align with our system strategic imperatives. In addition, I've highlighted our EITS support and our body of work around the second surge for COVID-19, pausing there to highlight also that during that particular time at the end of December and beginning of January, we did pause a couple of projects, and our staff, who were clinicians, pharmacists and nurses and some project managers, were actually realigned to work in Elmhurst and other hospitals to support the kickoff of the COVID vaccination clinics. And then in addition, you will find a high-level overview of the HIT prioritized projects, of which there were 10. 2 of those have come to completion, one with MDPA, which is the MD staff, which is a credentialing program, as well as the successful merger of NCB and Jacobi. And then in conclusion on the report, you will find 2 key areas of IT continuous quality improvement, and our focus there was on the print management services, which support the efficiency and effectiveness of printing, as well as security around the printing. And then the last piece for the quality improvement is our next step with EPIC training. We call it the Thrive program. And in that first kickoff of the Thrive program, the team there has developed the Joint Commission overview. So we'll get continuous feedback from when we have our surveys, and we will continue to augment that. And the goal there is to help navigate individuals, help support the navigation during a survey of EPIC. I am going to pause and have Dr. Michael Boughton, our CMIO, provide just a brief update on 2 of our dashboard metrics, biomedical device integration, as well as my chart. Michael?
Thank you so much. So biomedical integration, this is where we basically bring in vital sign parameters. They can be a dialysis machine. It sends its data into the electronic medical record. 5 years ago, what would have to be done is a nurse would have to walk over the dialysis machine, write down the blood pressure, write over the dialysis clearance percentage, walk over the electronic medical record, type in the data. This creates error. This is not the best use of our staffing resources. During COVID, dialysis was particularly hard hit. We needed to be maximally efficient in this area. So taking away non-value work from our clinicians, from our doctors and our nurses was hugely important. So we've done a bunch of work in this space in the past year. And this coming year, you'll see what our goals are. We're going to move from 47% to 70% integrated. This gives physicians access to timely information that they can then act on more appropriately. And this also, as I said before, it makes our staff more efficient by not having them have to manually do data entry.
And if you go to the next slide, David, you can see our progress to date.
Yeah. So this is our year goal for where we are. So we are currently on track for this year.
Correct. And then our next slide, David, and we'll conclude here.
So for MyChart activation, so MyChart is the portal by which patients engage with their healthcare information. You can see here that we are now comfortably above both the EPIC national average and our 2020 stretch goal. What's significant about that 2020 stretch goal of 50% is that it initially was 30%. And when we realized we were going to clear that bar, we got more aggressive, and then we cleared that bar. This is an unmitigated success for our organization. And part of it is naturally because of COVID. People had more of they needed to get their COVID results. I can tell you a year ago, the Epic average is about 37%, and that's 350 organizations, the top 20 organizations across the country in healthcare. So I think it's a representative average. That's now 48%. Well, we moved from 15 to 66%. So we have far outstripped that. So it's not just COVID here. This is really about us making the electronic medical record available to our patients. If you come to see me in the emergency department today, you can at the end of that visit, log in and read the note that I wrote for the patient. You get your COVID test results there, and we've also made it a lot easier to sign our patients up. So we tried to make it both useful and easy. I'll stop there for questions.
Thank you.
Questions?
Thank you for a very exciting presentation. It was.
Why, thank you.
Certainly very, very informative. Exciting might be strong, but no, in all seriousness, this is tremendous work, Sally. I agree with you. No, I agree with you, Sally. It's really important. One comment I would like to make, though, because naturally, you do an amazing job, and I think that's tremendous. I think naturally, though, we always look at the weaker players here, the laggards, and there's such a big discrepancy between the higher utilizers of my chart and the lower. And any thoughts of explanation and any action taking at this point to try to remedy that?
Yeah, 100%. So I'll say a couple things and then what we are getting to improve that. If you notice our lowest players, those are actually at the national median. So I want to start by pointing that out. This is our uncut data. We cut this data many different ways, one of which I think is relevant to your question is if a patient has a primary care physician at your facility. For both Woodhull and Harlem, which you see down at the bottom there, their numbers increased 20% on those metrics. When you look at the top, you see Cumberland, ENY, those are places that already really only have primary care doctors. The patients that come to the emergency department, they're going to have lower numbers to start with because they're not all patients that are seen at our facilities. So that explains some of the differential, but not all of it. So what we are doing is the facilities that are lower on this list are talking to our facilities that are higher on the list about best practices in this area. The technology is the same across all of them. If you come in for a visit, you automatically get an email signing up on your after visit summary, which is the paperwork you get. There's information on how to sign up for MyChart. Really what it comes down to is staff engagement, talking to patients about value and having that conversation. And that's what we're driving right now with our clinical partners.
I think the other thing to keep in mind is when it's an acute care facility, that all of the patients that come to the acute care and the ambulatory are part of that number, the denominator.
Yeah.
Where when you look at the one like Cumberland and East New York, they are just they're just the ambulatory and the primary care provider. So it is a little bit of a mix as far as what the denominator is.
Yep.
Gotcha. Other questions or comments? Yeah, again, just great work. And, thank you for that. All right, so that being the information items, go out of sequence. I'm sorry, was it someone commenting? Okay, we're going to go out of sequence for the action items. And Dr. Long, if you can bring up the item on the plans for expansion.
Dr. Calmia, this is Ted. Do you want me to bring up to share my slides myself, or I see on the screen here that you have my slide deck?
Excuse me one moment. This is the court reporter. I think we can take a few minute break.
Go ahead, Kalisha.
Hi, this is Kalicia Hercules. No, we are not able to take a break at this point. We are recording and we could forward you the recording.
I have to use the restroom. I have to use the restroom.
I'm sorry, we would forward you the recording. You can come back when you're finished. We'd forward you the recording. We have to continue.
Oh,
Dr.
okay.
Long, the presentation is up and we will move on. Thank you.
Okay, thank you.
Okay. Dr. Calmia, let me know when I can jump in.
Yeah, please go right ahead.
Okay. Hi, everybody. This is Ted. So I'm going to walk through the presentation today. The backdrop to this, this is around our canvassing work, which serves two purposes for us with respect to the test and trace core for New York City. Number one, our canvassing work is how we get through to people to get them to come out and get tested. And we've been very effective there, and I'll share some data with you in a moment. Number two is our canvassing work now serves a new role in terms of facilitating the enrollment for people to get vaccinated. In particular, our canvassers have gone to places like our NYCHA developments, other hard-to-reach populations in New York City, and have uniquely been able to bring people out for vaccines. And we know that that's an effective strategy because when we haven't done it, we have not seen the same effectiveness. So to walk through the presentation here, those are the two key reasons why we have our canvassing effort and why we want to continue it moving forward. The backdrop is we did have an RFP and CRC approval process that was conducted to solicit vendors, and I'll tell you a little more about that process at the end of the presentation. And we landed on 6 firms that have been contracted with today with a not to exceed amount of $20 million. We're at the point now where we want to go beyond that not to exceed amount so that we can continue the good canvassing work, which I'm going to tell you more about. Next slide, please. So what we're specifically asking for approval today is not to create new contracts with other firms, but rather to keep the same firms that we used the RFP and CRC process to identify, but add more money to what they're doing, because right now we're going to be out of funding by the end of April 2021. I want to follow up that statement with an apology that I know normally we come to the board earlier on to give more time to think these issues through and to make decisions. Unfortunately, with the pandemic, we've oftentimes found ourselves having to react a little bit more quickly. So I hope that you'll accept my apology in terms of why we're bringing this to the board today, because we didn't know that this would be such an acute need before, given the effectiveness of our canvassers in getting our most vulnerable New Yorkers out there to get vaccinated. In terms of the current canvas shifts that we would be able to do here, our current number is 460 per day. And our projected number, if we are able to receive your approval for a not to exceed amount of 60 million, would be to double that to 1,060 per day. One important point to bring up here, and these are probably the most important numbers I'll share with you today, so I'll go into a little detail for a moment, is the $20 million that we have right now. This is based on questions that came up last time, which are great questions. That $20 million buys us 2,100 shifts. For testing and for the vaccine effort from canvassers, 2,100. With the not to exceed of 60 million, that will buy us 6,815 shifts. So actually we gain a little bit of efficiency and we get more canvassing for the dollar there, if you will, by going up to the not to exceed of 60 million from the 20 million where we are now. Where we are now, we're going to be out of funding by the end of this month, hence bringing it to you all for your consideration today. Worthy of note, I'm just going to mention this last point and then I'll go on. Neighborhoods designated by the Task Force on Racial Inclusion and Equity have significant racial and economic health disparities across the city. And one of the key things that our canvassing efforts allows us to do is to go into these neighborhoods and find the most vulnerable New Yorkers, especially people 65 and above in these neighborhoods, and facilitate their enrollment to get the vaccine. And it's been very, very effective in allowing us to get the most vulnerable New Yorkers vaccinated, which is so important to keeping our city safe and saving lives as we wait for the vaccine to take full effect. Next slide, please. So the way this works financially, and we added this information based on your feedback from the last presentation as well, is that H&H has an MOU with OMB for how funding flows. Activities like this through the Test and Trace Core are eligible and receive funding through grants. So these are not outlays from our H&H budget per se. The canvassing efforts from Test and Trace for testing is we use the CDC ELC grant, which is a large CDC grant to fund, and the vaccine canvassing efforts where we go and find those most vulnerable New Yorkers and bring them out to get the vaccine. We use FEMA funding for that. And I'm joined by our finance colleagues, including Sonia Rubin on the phone, on the WebEx today, to go into more detail if you have questions in a moment. OMB has fully reimbursed all H&H canvassing work to date, consistent with the MOU that we have. And I share a few more details here in terms of the numbers. The not to exceed increase will cover expanded canvassing work through the end of September 2021. And the reason that matters is we want to have 5 million fully vaccinated New Yorkers, which we will achieve by the end of June, and then over the summer to continue to have targeted efforts to make sure that we can get those most vulnerable New Yorkers who have been through or in our hardest and most impacted communities and need this vaccine to literally save their lives, to get them vaccinated, to keep them and therefore their community safe as well. And those activities will continue past June through the summer. Next slide, please. So in terms of the program details, I alluded to this a minute ago, but the way it works is our Canvas teams work with the citywide Vaccine Command Center to identify areas, in particular those communities that have been hardest hit and that have the most profound racial and economic disparities in terms of health outcomes to date and the effect of COVID on our communities there. And we call those the TRIE neighborhoods. With Canvasser assistance, that's how we're able to identify individuals at highest risk in those communities, bring them out to get vaccinated, and it's been very, very effective in allowing us to do that. Our Canvas efforts to date, there's been 547,000 New Yorkers that we've been able to commit to getting tested. And by the way, that effort right there has contributed to New York City having one of the highest per capita testing rates in the whole world. We only are surpassed per capita by some countries I think in Eastern Europe, like Slovakia and Luxembourg. Otherwise, we do more per capita testing in our city here than any other country in the whole world. And it's because we have these efforts, in particular this canvassing effort, to get the word out and to help people to come in and get tested. We've also done, facilitated enrollment for more than 50,000 New Yorkers to get vaccinated. And those are 50,000 New Yorkers that are in our most vulnerable communities, that are the most vulnerable people themselves. So it's been really important to saving lives in New York City. And then also mask distribution, we all know, has been a critical piece of how we've been fighting back against COVID. Through the efforts I've described to you so far, we've distributed more than 7 million masks. So if it wasn't for our canvassing effort, if we weren't doing this, we wouldn't have been able to distribute 7 million masks to date. We want to do more of that. To mention cultural competency for a moment, the canvassing firms hire directly from our most impacted areas. So our canvassers are New Yorkers that live through the same things that the people in the communities that they're engaging with have lived through and are living through now. They get it, and New Yorkers trust New Yorkers that have been through the unfortunate, the events of last March and April in particular. We also regularly partner with local elected officials, CBOs, faith-based organizations, tenant associations, and other community stakeholders as well. Next slide, please. So in terms of an overview of procurement, we had an RFP that was posted in the city record. Content was approved by CRC. 16 firms responded and 6 were selected. We entered into contract with those 6, to say them out loud: AM LLC, Full Contact, Mosaic, Reserve, Connected Strategies, and Danoon. What we're asking for today is not to enter into any new contracts with other firms, but rather to use the 6 firms that were selected through our RFP process that was approved through CRC, but to increase the amount of money to a not to exceed of $60 million so that we can continue efforts past April, when our current $20 million will run out, and continue to enroll the most vulnerable New Yorkers to get the vaccine as quickly as possible. Next slide, please. This is a slide that just shows the cost per canvasser per 8-hour day. You can see the amounts are fairly similar. I won't go into too much detail here because I know we're short on time. Next slide, please. This here shows one of the numbers I was referring to earlier, which is that our current $20 million for the not to exceed buys us 2,100 shifts. Going to $60 million will buy us 6,815, and those are the numbers on the right-hand side. If you add them up, it's 6,815. So actually, you're getting more canvassing per the dollar than you are with the current $20 million not to exceed, and it allows us to do just a tremendous, tremendous amount more. Next slide, please. For the recap of the procurement process, I list for you here the evaluation committee, I list for you the evaluation criteria, and I list for you the MWBE status for the 6 firms that we've gone into contract with, which I'm happy to answer more questions about in the presentation. Next slide, please. Okay. Dr. Calamia, would you like me or somebody to read this or to go to questions?
Yeah, if you could. This will be the actual pending action. So yeah, if you could, please, thank you.
Happy to. Authorizing New York City Health and Hospitals Corporation, the system, to amend 6 agreements for neighborhood canvassing as part of the system's response to the COVID-19 pandemic with AM Trace LLC, Full Contact Communications LLC, Mosaic Sales Solutions, Reserve, Connective Strategies Associates Incorporated, and Janoon Incorporated, the vendors, previously signed under emergency authority to increase the total spending authority from $20 million to $60 million. Thank you.
Okay. Questions then? We'd open up to questions. Sally?
Yes, Ted,
Yes. Hi, Sally.
how are you?
Good.
I'd actually have many more questions if it was H&H funds. So I'll just limit my questions and I can take some, offline later on. I'm focusing on the Canvas performance metrics to date. You're now switching more to vaccination canvassing, which I think is a wise idea. But you've got 547,000 New Yorkers committed to get tested, and only about 10% of them scheduled appointments. I was wondering if there's any follow-up with the folks that have committed, or is that, I'm not sure what the meaningfulness of that metric is, except to show that, the 50,000 I still think represents a good percentage of the total vaccinations. Do these count for total H&H vaccinations to date?
So thanks for asking, Sally. So just to delineate between those 2 data points, the 547,000 people that committed were committed to get tested. So we then direct them, sometimes even walk them to one of our testing sites where we have our rapid testing machines, things like that.
Okay.
The 50,000 people, that your second number there is the vaccine appointments that were made. So there's the 2 different populations of people there. Yeah, but
So you don't, I guess because one started later, you don't have people getting tested and then being offered the vaccine in the event that they're negative. Those are two separate types of canvassing.
separate for canvassing, but linked in terms of what we do on the health and hospital side. So today, anybody with a negative result, when you get your message through MyChart about your negative result, we offer you connections to getting the vaccine at that point. So your point is really, really important, in that testing is an opportunity to forge the connection to get people the vaccine, in particular people with a negative test. So we're doing a lot more in that area today, just to emphasize what you're saying, and we're going to do a lot more there too, to have people that have been tested negative to get the vaccine.
I think that's so important, because doing it through the phone-in system, having done it, is a very complicated process. And are you revising the RFP to reflect the change now to more of the vaccine canvassing, or is it broad enough to just include this?
It's broad enough to include, and I'll ask Jonathan Vigers on my team who's joining me if he has thoughts on that. But we're already doing it under the current RFP, so we believe that it's broad enough. Jonathan, anything you want to add there?
Yeah, no, it definitely is broad enough, and the firms are willing and able to do both vaccine and testing work.
Okay, and just one last question. The original contract was 5 years for $23 million. Maybe I'm not reading this right. Now it looks like 3 years for $17 million. Is that not right?
So Sonia or Jonathan, do you guys want to go over the initial and the new dollar amounts?
Sure. The original contract, the original RFP and contract was for $20 million for 6 months, and now we are expanding it to $60 million and through the end of September.
Okay. I don't know where I got years from. Okay. Thank you.
And actually, Sally, to emphasize that point you're making too, because this is really, really important, is that the current $20 million will run out at the end of April, the April that we're in now. Hence why we're bringing it. And with the pandemic, things happen so fast. This just turned out to be a very effective strategy. That's why we wanted to bring it back to you with all the information today.
Oh, sorry, I was looking at another contract. Sorry.
It's okay.
Thank you.
Thanks, Sally. Fenny, I think you have a question.
Yeah, Dr. Calamia. Hi, Dr. Long. How are you? Thank
Penny,
you for your
good.
presentation. I do have a couple of questions, and different than Sally, I still worry about resources, even though it's not paid by Health and Hospital, because I believe that is always good practice, because it creates a culture of being a good steward of the resources that we are entrusted. I do have a question in terms of, the increase that we're speaking here is 300%, which is significant for any contract. And I do notice that, for example, if we were to go to the breakdown of the charges per vendor, if we go to that table, please, so that we can all, yes. You do notice here that depending on the amount of money committed to a vendor, the price per shift does change. So definitely there is an economy of scale. So my concern is that at this point in time, I do know the pressure of time, as you have repeated a couple of times, that we are running out at April 20, at the end of April. I don't know which particular day. We are kind of in a challenging position. As you say, this is a program that we all consider important to ensure that New Yorkers get vaccinated and tested and really kind of limit the impact as much as we can of COVID-19. But you do see here that there is an economy scale with size of contract. So one will imagine that if this contract were to be let out for procurement, there will be savings, because now we are talking about 3 times as much money will be put into those contracts. So my question is, what is the best interest rationale to keep these vendors and increase the contract for, and what are the analysis that was done in the cost benefit for the resources that are going to be put into this increase, both in amount of money and also in time?
Yeah, great question. So I'll start off by going talking about the economies of scale point you brought up, and then I'm going to turn to Jonathan to talk about the performance of the vendors, and maybe he can go over for us the RFP process to show how we really rigorously looked at the vendors that had applied. So the first $20 million will be up at the end of this month. So then effectively you're looking at the next $40 million beyond this month. So in terms of the changes with what we get for the extra or the increased amount of money there, the $20 million got us 2,100 shifts, and the not to exceed, if we go up to 60, would get us 6,815 shifts. So we're getting a lot more canvassing in terms of economies of scale for that larger amount. It's not like we're just taking the incremental increase and we're getting exactly the same. As you pointed out in the slide, you're right that with the increase to $60 million not to exceed, we are getting more canvassing for the buck, if you will. For these companies, for these firms in particular, we actually did have a very rigorous process and we work with them very closely. So Jonathan, can you share your thoughts on one, the RFP process for selecting them, and two, you work with them every day, how their performance has been?
Sure. So the RFP process, we had 16 firms that submitted, and we chose to go into contract with the top 6, specifically because we weren't sure how quickly or how fast we would need to expand, or if the need for positivity rates or vaccines. So we went with a slightly larger pool than we would have in the beginning, because we wanted to be able to have this capacity if the sort of situation came to it, and it looks like it did. We were basing it, the evaluation criteria was, the pretty typical standard: cost, relevant experience, ability to scale, data management, and community and language expertise, as well as MWBE. And I just do want to say that I think one of the major benefits of working with the vendors that we have in place is that they have been able to already hire from the communities that they have been working in. So if we go into a new procurement process and restart this, we would have to, let go of all of these people and then start that process over again when we have people that are working from the communities that they are serving. And that's a big part of how we deploy them. We deploy them based on where they have relationships, where their sort of employment base is from, as well as the languages that they speak and the languages that the communities that they serve speak. So I think that all of that sort of plays into why we would like to keep these firms on track and continue to doing the work that they've already been doing for the last couple weeks and or months in some cases.
Jonathan.
In that case, following up on your, I think what I understand your rationale is that this firm has familiarity with the neighborhoods that they're working, and they have been hiring from the communities. I think that's what you are saying, that will be the two primary benefits of extending this. Is that correct? I just want to make sure that I understand what were the two.
And that's the same approach we've taken with contact tracing as well. Our contact tracers are all from New York City. More than half are from our hardest hit communities. And cultivating that trust has been our secret ingredient to success.
So in that case, is it possible to provide the numbers? Again, I'm kind of a quantitative type of person. The numbers of how they have done and performed in hiring from the communities. I do not believe I saw any of that information here, so that at least there are hard numbers to show that they are really indeed hiring from the communities that they are serving. Or do you have those numbers right now?
If we don't, we can get them to you. It's a great question. Jonathan, go ahead.
Yeah, I don't have them handy, but I can get those.
That's a great question. Yep.
I think that would be extremely good to showcase, because that's what we are basing the premise of why kind of going the contract. Still, I will suggest, again, this is just a suggestion, that I do not believe, and I think a lot of people also do not believe that COVID is going to go away come September. There is going to be a long tail. And again, if you read the reports, there is going to, the remaining people that needs to get vaccine is going to be still lagging. And so for good practice, I think, and again, you're bringing us this very much in the month that inspire, that you really think through, because I think it will be a little bit challenging to come back in September and add more money to this contract, so that you think, because in a lot of cases, in cases like this, these individuals can compete again, and so it doesn't mean that people will lose their jobs, but you may get more competitive pricing arrangements. So I think it should be considered if you think that we're going to pass September, which a lot of people may believe so. So that will be one point. The second point, which is actually also very concerning to me, is when we go to the MWBE. You mentioned that during the time that you did a contract, the MWBE was part of the procurement. However, the words that I see here, it says committed. It doesn't speak. You're saying that we're already spent the money, more or less, because it's finishing up at the end of this. So there should be data on how much money they spent in MWBE. And I don't think that has been provided. Do you have how much is the actual, because again, you mentioned that by the end of this month, we will have spent all the money. So the money has to have gone somewhere.
Great question. Jonathan, do you want to handle that?
Sure. On here, all of the firms that identified have all been entered into contract. So they are part of the contract for the ones that are not full MWBEs. We can give you a breakdown of where the money has gone to so far, but I don't have that in front of me at this time.
We can follow up with that, though. It's a great question.
I think, again, if this resolution were to pass, I think it will be good to provide that to the full board presentation to have, because again, the words here, it says identify, which is very, very loose language. Definitely doesn't say that they have contracted for this, and it doesn't have the number of how much is the percentage of allocated, because when you go into a contract, there is a breakdown who are the subcontractors and how much money you are doing. Like you're saying, you're showing in that table, you show the resources. So I think it has to be because we already spent $20 million almost. There should be enough data to showcase that expenditure in all of those firms, and who had they contracted, not who they have identified, who they are talking to, who they are thinking to, but thinking of is like who they are contracting. The other question is that I do see a particular one that does not commit to NWB, and that is concerning because, as you say, all this type of outreach is for communities that have been greatly affected. And, the statistics show that they tend to be more communities of color and minorities. And having, we're talking about canvassing. That means talking to people. And it's like talking to the same, your same people. It's a little bit challenging that a firm, particularly one that is going to be now the third largest in providing shifts, because according to your number, if we go back to the table that you showed for the projection of shift for the future, the Mosaic is going to be the third largest of shift service providers. So, like, for example, the largest is BMG with 2,350 shifts. And they have committed to the 30%, and I do believe that they have spent 30% already of their allocation of the 20 million. AM LLC is with 1,170, and then Mosaic is 1,160. So they're going to be the largest, the third largest, and they are not committed to brand. So I'm very concerned with this type of arrangement. Can you explain a little bit why is that case?
Jonathan, go ahead.
Yeah, so the Mosaic was waiver were given on the basis that it's self-performing. So if you go back to the other slide, you can see that 54% of its employees, including the field staff, are self-identified as people of color, and 56% are female identified. So that's in addition to the leadership. So all of their staff is W-2 full employees. So that is the basis for where they, why they were given the waiver and why they are identified as a firm that we were able to enter a contract with.
Well, I will say that if you look, and the reason why this goal is set, because if you ask any company, they can actually self-perform. I think if you were to ask all the firms that have committed to the 30%, they will have the ability to self-perform, because what you're saying, they are going to go and hire people from the community and add it to the payroll. And if you see, they are making the commitment based on how long you are providing funds for. So I believe that all of them will have similar characteristics. Like, for example, how is the composition of the personnel for AM LLC, for full contact, for all of them? And I don't know if you have that data, but logically, I think it will be very similar. So I'm a little bit concerned about this waiver, and I do believe that if this were to go forward, this issue is addressed with this vendor, because they are going to be the third largest provider, and their justification in terms of the composition of the personnel, I think if you were to show the composition of all these vendors, will be very, very similar. And if you were to go and ask all these vendors, they also will have to say that they can self-perform. So I would say that this is something that particularly, again, we're talking about talking to people, relating to people, bringing them to be tested, bringing them to get the vaccine. So, you know, we have heard so many times the issue that, well, we cannot find MWBs because this is very specialized. This is like proprietary information. Here we are talking about that to provide services to your own community with your own people, you still cannot find the individuals that can meet the NWB requirement. That's very challenging for anyone to understand.
Mm-hmm. So, Fenny, it sounds like there's 3 follow-up items that we could bring back for you. One is the information on the hiring patterns from those in our hardest hit communities. 2 is more information on MWBE spending now that we've spent money. And 3 is on the Mosaic firm in particular about their MWBE plan and how they're performing the canvassing work now. Does that make sense?
Yes, and I hope that you know, you understood the comment in terms that you know, this is a goal that if there is a set of contracts that should be easy to meet this goal, this will be it, because this is talking to our own people and the same communities, and it's hard to believe that we cannot find people qualified to perform those work.
Yep, understood. Great point. So we'll circle back on all 3 of those things.
Super. If you could actually get some of that information to Fenyaski, that would be helpful in advance, but certainly by the board meeting, that should be part of the presentation.
Definitely.
Great. All right, if there are no other questions, I'd like to jump to then voting on the proposal as is. So let me start. Fenyaski, why don't you favor?
My vote is conditional on that information.
Do you want to make that a contingency then? Should we change?
At least from my vote, yes, that will be a contingency.
All right, can we then do that? We'll have the same proposal with the contingency that information will be present at the time of the full board meeting?
Yeah.
I'm sorry, Benny. Alicia, can we make sure that's arranged that way? Great. Fenny, based on, is there an approval or no?
I think based on the data, I will need to be, you know, it has to make rational sense, not just the data being provided.
Gotcha. Okay, so let me move on then. Jose?
Yes, thank you.
Sally?
Yes.
Barbara?
Yes.
Okay, super. So then I have, I'm a yes as well. So I have it 4 yes. One, they sort of abstain in a sense because we're waiting for contingency to be met. Well, actually, we're all voting in favor for our affirmative. We're also voting with the contingency. So our expectation is that will be presented at the full board meeting. So the motion does pass. With that, Fanny, I'm going to turn the meeting over to you. I'm actually recusing myself from the last action item. And thank everyone. Appreciate so much your very long but very, very informative meeting. And I appreciate all of your attention. Thank you.
Thank you, Dr. Calamia. Have a wonderful day. Now I would like to bring, I think Dr. Chi is going to present the Change Healthcare resolution.
Thank you. I'm going to open it up. I'm going to ask my team to join me. This is the presentation of the Change Healthcare, formerly McKesson, application for a best interest contract renewal for the radiology transformation program. Over the previous 5 years, New York City Health and Hospital radiology directors.
Excuse me, can you read the resolution into the
I'll
record?
read the resolution first. Authorizing New York City Health and Hospitals Corporation, known as the System, to sign a 3-year best interest renewal contract with Change Healthcare, Inc., the vendor, for an enterprise-wide radiology diagnostic management solution with 2 one-year options to renew the contract, exercisable only by the System, and with the total cost of the contract over its full potential 5-year term of $15,875,046 with a 10% contingency of $1,587,505 for a total expense not to exceed $17,462,551. Should I proceed?
Yes, please.
Okay. As I started earlier, a few minutes ago, over the previous 5 years, New York City Health and Hospitals radiology directors have worked with Change Healthcare, previously known as McKesson Technologies, to establish an enterprise-wide, single-vendor, integrated imaging system for the H&H enterprise, which is the state-of-the-art among healthcare systems. The enterprise-wide imaging system, which has been built by Change Healthcare for New York City Health and Hospitals, includes a single PACS system, a unified vendor neutralizing archiving system for imaging repository, a single enterprise work list, which allows any and all images to be read from any workstation within the system, a single clinical viewer, full integration of the imaging system with our EMR Epic, a fully integrated dictation system, an enterprise-wide business intelligence and analytics system, and a concierge system for direct delivery of critical results by the radiologist to the ordering provider in real time. We will present to you the need to extend this contract in order to put in place enterprise-wide upgrades along with training and knowledge transfer to our own staff in order to bring this new technology and maintenance, quote, in-house, end quote. We will also present to you why going out to bid for a new vendor with a resultant deconstruction of these gains achieved over the past 5 years would be prohibitive, not just in financial investments lost and new financial investments required, but also would present to New York City Health and Hospitals a tremendous setback in terms of losing our place among New York City healthcare systems in the radiology universal imaging sphere. It would also result in the loss of 5 years' worth of labor and technological progress, plus the loss of an additional 2 years for a potential new vendor to lay the groundwork to rebuild what has already been built by Change Healthcare. I would now like to turn the presentation over to our team, David Shee, Senior AVP, MMPA Radiology Services, Al Garofalo, Senior AVP of EITS, Keith Talbay of the Office of Legal Affairs, Joe Wilson's the Office of Purchasing, Michael Ambrosino, who's the co-chair of our Radiology Directors Council and chair of radiology at Bellevue, had a conflict at 10:30, so he's not able to join us. So David, if you can continue.
Yep. On the background current state, as Dr. Allen mentioned, we are here to request the renewal of our contract with Change Healthcare. With the current contract, Health and Hospital has transformed our radiology infrastructure from a primarily facility-based model to an integrated enterprise solution. This enterprise solution is now being implemented at all acute care Gotham facilities, as well as our post-acute sites at Carter. The total spend is $22 million, $1,210, and the contract sets to expire on July 22nd, 2021. As a result, we're requesting to renew the agreement for 3 years with 2 one-year options. Next page, we'll ask
Good
Dr.
afternoon.
Yeah.
Joe Wilson from Strategic Sourcing. Under the Systems Procurement Operating Procedure 100-5, where it is in the system's best interest and where supported by a cost-benefit analysis, the system may renew a contract rather than re-procure. The vendor solution is providing a substantial benefit through its software and services and continues to perform well. There is a lack of opportunity in the market were H&H to switch vendors to either gain in technology or in cost. The price for this service has not increased on a per unit basis since being competitively procured 5 years ago. And market analysis shows no price savings are to be gained based upon the industry pricing benchmarks. I would like to pivot to Dr. Garafola to speak more in depth about the issues with changing vendors and the significant disruption it would cause clinically and to business operations.
Sure, thank you. So there would be a significant cost and time loss if we were to switch vendors. I'm just going to highlight a few points. The resources and work that would be needed to import the studies. There are about 18 million radiology studies that we have now in our current PAC system. They would have to again be imported into a new PAC system. We'd have to perform an entire quality assurance on that import, which we did the process from a few years ago. There's also files that are very unique to those images. Some are called training files, which radiologists use to train some of their residents. Those are unique files. There are annotations that mammographers make and others make to those radiological images that don't normally transfer over with the DICOM, which is another word for those images, during a normal transfer process. That has to be a manual process of remapping and QAing. We need to develop, again, a standardized work list for our radiologists and subspecialists. So that means the mammographers and the neuroradiologists have very unique work lists in which they work off of as these images are processed and need to go to them for readings. And that has to change based on the facility needs. Some facilities have these specialists, some facilities don't. And that process has evolved over about a 2-year work effort on our part here, and that would all have to be repeated. Another concern is the modalities. There are about 800 plus modalities out there, both the standard X-ray machines, mammography machines, ultrasound machines, and all of those need to be reconfigured again with a new vendor. And not only do we need to have the manpower on our side to do that, we need to ask the vendors to come in. So GE and Philips would have to be realigned, come back in again, reevaluate those machines, because all of that software is proprietary. Now, we've gone through the process of upgrading a lot of that software, but there can be situations where the hardware may not work with the new vendor, and or there'll be another lift for upgrading of that particular software. The training involved, we have about 150 radiologists, hundreds of technologists, PACS administrators, and physicians that would need to be retrained on the new system. This mask. The prior transformation averaged about 9 million, excluding work for what I just mentioned, data and DICOM images, migrations, licensing, work list implementation, and the viewer configuration. All that is about additional $67 million that isn't taken into account. I just want to make one good point. The implementation costs are not only what we pay the vendor for services, but also the expenditure of our own resources, technical and clinical, loss of efficiency due to radiologists, technicians, and staff. Thank you. Next slide, please. Okay, quickly with this slide. It does share our leaders and our evaluations. On the left is the market share of the current vendors out there, and you can see Change Healthcare is about 18%. This is the middle slide, indicates the PACS vendor change, those that are switching from and switching to, and again, Change Healthcare continues to lead in that arena. And the one on the right is for the class radiology, and that's a very interesting point. Class is based on not vendor ratings, but on how the individuals and the academic institutions rate that particular vendor. So you can see Change Healthcare is still leading in that arena. So that's not based on, let's just say Epic is the leader based on evaluations, but Change Healthcare is the leader based on how the academic institutions who currently have it feel confident about continuing with it. So that's a very significant point. Oof. It's the mask. Sorry. Quickly on the next slide. Oh. Well, the next slide just goes over the accomplishments of the next 5 years. And I think Dr. Allen covered that very good in her opening remarks. Next slide. Oh, okay. So am I.
Yeah.
There you go.
Thank you. Dr. Allen, did we finish the presentation?
Well, we have technical difficulties. We can actually talk through it with the view to see the slides. The next two slides actually speak to the enhancements that Change Healthcare would provide us. In the interest of time, Al, do you want to just run through
Yeah,
them?
just quickly, some of the advancements that are going to be happening over the next 6 years and so on would be the DICAN, DICAN integration for cancer screening for both breast and lung, our EMR VNA, which is called the Virtual Neutral Archive, which is the ability to ingest images from other systems, cardiology, for example, dental, gastroenterology, ophthalmology, and that would make them available for the user in Epic so that they don't necessarily have to go into those other third-party systems to view those images. We'd have advancements in voice and collaboration tools for the end users and also for the radiologists, and then advancements in artificial intelligence with clinical algorithms, bringing relevant prior studies, and giving the radiologists sort of that aha moment of bringing maybe an image about 3 years ago that could have been questionable, and just bringing that to their attention that there is an image for comparison and similar of what's being done at this particular moment.
So I would like Keith Talbay to walk us through the MWBE plan. Keith, are you on?
Yes, thank you, Dr. Allen. So the MWBE plan for McKesson Radiology Integration and Software. So most of the professional services were performed in the original 5 years. So the remaining bucket of services that is 1.6 million, which is approximately 10% of the total contract value. The remainder being the software licenses themselves, and then the maintenance component of the for the software, which is all self-performed by Change Healthcare. So that the only piece that's not being performed by Change Healthcare is program management, representing 10%. It is being subcontracted to an MWBE partner named HR Consulting, and New York State certified women-owned business. Under the original agreement, just for context, there was another piece of business that Change Healthcare was not self-performing, which were concierge services. Those services were also being performed through Atria Consulting. We brought those services into direct contract with H&H, so that's no longer an opportunity under the contract. So the only portion there being that 10% for program management, and that is being subcontracted to a New York State WBE. On the next slide, workforce diversity.
We don't have slides, Keith, so you're just talking to it.
So what is the next slide, which is a workforce diversity slide for Change Healthcare. The work being done under this agreement is decentralized for Change Healthcare across their corporate entity. They have a large proportion of remote workers. As a corporate workforce, there are about 2,600 employees, 59% of whom work remotely across 41 states. We can't do a statistical analysis on those data because of that distribution, Penny. But it looks like they're fairly well represented for women, a little underrepresented in the IT job group category for women, which we've seen historically across other organizations. And, you know, they have focused efforts on STEM and recruiting regarding that. And then the largest single workforce was Georgia. So we did take a look at Georgia. We haven't done a full analysis on that yet, Penny. They did provide us with some data which showed one underrepresentation from their own analysis, again, for females in IT. And that's 443 workers in Georgia. We're going to do a full analysis across Georgia, but you know, there's just that bit of a problem that they have such a decentralized workforce, and there's no single location that is performing the services for us.
In the interest of time, I'm going to move forward. I'm going to ask David Shee just to hit very lightly the vendor performance evaluation to date, and then we'll wrap up with the last slide, which is our formal request.
Yep. On vendor performance, we found that Change Healthcare has met the majority of vendor performance criteria. The one area that we see key improvement opportunity is related to the staffing level for service support. And that is because, as we learned through this transformation program, an integrated enterprise solution would require higher level of service support. So one good example is when system issue occurs, it will typically affect all facilities instead of selected locations. And this also applies to improvement and optimization initiatives, because change request from one facility could trigger the workflow and the system change enterprise-wide. Should we go to the next page?
Just the last page.
The last page is, we learned about this opportunity through the transformation process, and we have taken actions to improve, including requesting Change Healthcare to provide a dedicated support team for this project. And besides asking Change Healthcare to help improve their support, Health and Hospitals, through our Radiology Directors Council, has been proactively driving improvement, continuous improvement through our monthly meeting, weekly meetings with all key stakeholders from enterprise as well as vendors. So with this proposed new renewal agreement structure, as I discussed with Dr. Ambrosino, we're confident that the service support will improve, as well as the user satisfaction will improve over the next 3 to 5 years.
So that is the end of the presentation, and I'm going to end the way I opened. This has truly transformed our ability to provide radiology imaging services across the enterprise, makes us competitive with New York Presbyterian, Northwell, and actually the rest of the industry nationwide, to have one platform for all of the imaging services across all of our systems. This has been a true transformation. We'd like to continue the improvements and eventually bring this in-house. Thank you.
Thank you, Dr. Allen. Thank you, everybody, for the presentation. I would like to ask the fellow committee members if they have any question. Jose?
That was great. I just want, Dr. Allen, a clarification on the last statement you said of bringing services in-house. What did you mean by that?
I'm going to ask the IT people to answer that.
So Al can actually get us in more detail here, but what we are talking about is the additional support services that we will originally contract on, so that we will, over a period of time, 6 to 18 months, be able to bring that skill set internal to New York City Health and Hospital and be a more self-sustainable enterprise.
And that's correct. And the intent is to slowly peel them off as needed, maybe 3 down to 2 down to 1 over that 6 to 18 month period. And we'd be happy to report back to the board on the status of that progress.
Thank you.
Thank you, Jose. Sally, do you have any questions?
I just have 2 quick questions. One, it currently covers acute care facilities and Carter, right? And I'm wondering, did we not include the other nursing home facilities and corrections because the need isn't there, or is it an area we could look to expand to?
Well, the long-term care, a few of those long-term care facilities have their own third-party radiology system.
Okay.
And the work involved to integrate, it is the intent, but it's not on our immediate radar. And for the correction health, if I'm correct, I think they use a system called GE or something similar to that nature. And somewhere down the line, we can do the image migration. That's why we've gone out and have what we call the virtual neutral archive. We can also import those images into our own system and make them available across the continuum through Epic. So that is the long-term intent, but not right now. The amount of resource time we need to complete the transformation has been on our priority.
And my second question is, I know there's this reluctance to switch vendors because we have such an investment, and I understand that, but it seems like unless in 3 to 5 years there's some dramatic change in the technology available from another vendor, that we would be doing this again, maybe on a scaled down version, but it almost feels like we've kind of made a deep enough investment that moving away would be difficult.
I want to say yes, and I'm just going to give a quick response. I'm going to say yes and no on that. If you look at the market leaders now, they not necessarily were the market leaders 10 years ago. So in retrospect to what you're saying, yes, that's true, but you really don't know what the next 5 years and how some of these vendors will improve or change over that period of time. So probably yes, we'll stay at McKesson because not only are they now a market leader, they've been increasing over the years, but time will tell. But probably
Okay,
yes.
thanks.
Hey,
Okay.
Sally, can you hear me? It's
Yes.
Maureen.
Hi, Maureen.
Hey, how are you, my friend?
Good.
Listen, I just want to throw some additional information in. It took us a while to get the imaging at the nursing home squared away. We're using an outside service that has done a really, really good job. And to integrate to what, David is speaking right now, we don't have Epic, we have point-click care. So it's a whole EHR transition as well. And Carter, the LTAC has Epic, and that's why this is much easier for them. But we agree, we will certainly look to integrate and have one system across all of the, the 6 post-acute buildings. But right now, it's working really well what we have, and it took us about 3 years to get this in place. But as the EHR changes and as technology improves, we're certainly going to be looking at that as well. So I just wanted to share that with you, okay?
Thank you, Maureen.
Thank you. Thank you, Sally. Thank you, Maureen, for adding that information. Barbara, any questions?
None at this time.
Thank you. I just have a couple of questions. First of all, I would like to say to the group, you did an incredibly good job of presenting the best interest procurement, and the rationale that you presented was very clear, very understandable. One can see clearly the impact that it will have to change vendors at this time, and the effect that it will have in the practitioners as well as in the patients. So thank you for such a thorough explanation and so clearly communicated. I just have a couple of questions, and in terms of the MWBE. If we can go to the slides, please. I do understand the challenges with these vendors, and we have seen it in others as well, particularly as it relates to IT, the whole notion of proprietary information, kind of closed loop. But at the same time, it is important that we I don't think you have those slides. That's okay. I will speak from where it is. That was slide 7. So I do understand that right now, at this point, only program management seems to be the one available for subcontract. But I think it will be good to present, because you did such a wonderful job explaining so clearly the best interest procurement. So I think in order to be at the par with that thorough explanation, it will be good to get an official statement from the company that they do not subcontract any of the maintenance with anybody anywhere. So I think it will be good to show that they, as you say, they're working in 41 states, to really document that they do not have any sub-consultant to provide any maintenance in anywhere where they present. And I think it should be an official statement that they made, not just a verbal statement, but a written statement. So that will be something that will be at the par with the best interest. As you say, they're working in 41 states, to really document that they do not have any sub-consultant to provide any maintenance in anywhere where they present. And I think it should be an official statement that they made, not just a verbal statement, but a written statement. So that will be something that will be at the par with the best interest. As you say, they're working in 41 states. Okay, I think I was repeating myself on the video and the recording. So I think the system itself wanted to re-emphasize the importance of that. So The other part that I think it would be interesting, and I really appreciate the slide number 8, where it shows the workforce diversity that they made. I think we have to stop the echo because somehow I'm repeating myself, the system. Okay, is that we wanted to really have a statement in terms of their process to diversifying their supply chain. All the corporations now have, CSR, and as such, the social responsibility. And I think it will be important for them to share with us how they are really taking this seriously and identifying ways in which they I think we have to stop the echo because somehow I'm repeating myself, the system. Okay, is that we want. Okay, and the last one, and I know Keith said that it's very difficult, but for an organization that it is self-performing all their maintenance, one will believe that they have the ability to very clearly document the demographics of their personnel, because they are controlling those personnel. Doesn't matter if they are working in 41 states, it's only one company. So I think the statistics should be related for the whole company, because the services that they're going to provide is from all these places. So it will be good to present that information. And lastly, I know that in your analysis of Georgia, you present that the only underrepresentation is women on information technology, but I'm not so sure what metrics they are using. But if you were to look at executive in the company, they only have around 10% minority. I will consider that to be also underrepresentation, and I think it will be good to ask them for statements of their plans on how to address those underrepresentation at the executive level for minorities and the information technology for women. I think those will be something that will make sure that this analysis of the NWBE is at par with the wonderful, well-taught, well-communicated analysis that was done for the best interest renewal. So those were going to be my comments.
All right. So Fanny, let me just say on the workforce diversity analysis and the underrepresentation, we do that against the census data. So, and then look at 2 standard deviations. That's the, kind of accepted method out there for measuring an underrepresentation. And I haven't done that analysis on Georgia, and they said they were off by 12%. So I'll get that back to you though.
Okay, thank you. One is what is there, one is what we should try to, and I think, a company like this large, and, we are committed because as Sally mentioned before, and as it was echoed, if we look at the best interest renewal rationale, the likelihood that we are going to continue with this vendor for a long time, even though, of course, things can change in 5 years, is very high. So it's important for us to communicate to them the value system that we have and how we expect them to really raise to the occasion and fulfill those goals, even though they may not be able because they are self-performing the maintenance. That at least they show how they are approaching the diversification of their supply chain and how they are looking at the demographics of their employees in all the different elements of what is expected of a corporation nowadays.
Understood.
Okay. I don't know if there is any other questions. If there are no other questions, I would like to ask for a vote. Jose?
Yes.
Sally? You were muted, but I think you said yes.
Yes.
Barbara?
Yes.
I would like to be my vote conditional in that we provide this information in terms of their supply chain diversity and as well as the demographics analysis that is done. So I don't know, Colisha, how you record that.
I have it recorded on the record and it would be reflected in the amendment for the board.
I think with that, I believe that we just want to know if there is any new business. Any old business? Okay, hearing no new issues or all issues, I would like to adjourn this meeting. Thank you, everybody, and thank you for staying with us for so long. Thank you so much.
Thank you.
Thank you.
Bye-bye.
Thank you.
Bye. Colicia, now.
Yeah, but I don't want her to come in the meeting. I want the meeting. Okay. Hi, is the court reporter on the line? And is here also.
Are we still connected?
Yes, we are connected. I am just trying to square with the court reporter. I do not want to have a similar incident, and as soon as I square that away, we'd start, okay? Just
Thank you.
1 minute, please. She wanted to stop the other meeting because she wanted to go to the bathroom. So. Okay, Fanny, 5 seconds after the recording starts, you can go ahead. We have Frida, Jose, Dr. Katz, and Sally, okay?
Thank you. Welcome, and thank you for joining us today for the meeting of the New York City Health and Hospital Equity, Diversity, and Inclusion Committee. Today's meeting is officially called to order. First in the agenda is a motion to adopt the minutes of the Equal Employment Opportunity Committee meeting held on January 11, 2021. I would like to take a vote of all the committee members. First, Jose.
Yes.
Dr. Katz.
Yes.
Frida.
Yes.
Sally.
Yes.
Okay, the meeting are adopted. Next, we will have two reports, one from Matilde Roman, Chief Diversity and Inclusion Officer.
Good morning. So I just wanted to, if you can go to the slide where the graphs are. In January's meeting, we had covered workforce data, and I wanted to provide a side-by-side comparison about a workforce in New York City Health and Hospitals, the employee workforce versus the affiliate workforce, that you could see a side-by-side comparison based on the social identifiers such as race, ethnicity, and gender. As you see on the employee side, over 80% of the workforce are represented either as Black, African American, Hispanic, Latino, and Asian, and nearly 60% of the affiliate workforce also are from underrepresented minority groups. So it gives you a snapshot of the data. And if you go to the next slide, you shall see the same comparison both for employees and affiliate staff based on gender. And so it gives you at least some high-level overview of the global demographic data, both for our employees as well as our affiliate staff. I want to pause here, give you an opportunity to process and ask any questions that you may have.
Thank you.
Yes.
Thank you, Matilde. Sally, if it's okay, I would like to go in order so that everybody has a chance. Is that okay,
Sure.
Sally? Okay. Jose, do you have any question?
No, thank you so much.
Frida, any questions?
Just a question, a couple of questions, and thank you. This information is really important and useful. The affiliate workforce, is that all physicians?
The
Or-
affiliate workforce represents both physicians, allied health chiefs, and administrative staff. So it's a composite. It's approximately 6,500
Okay.
total.
But it's
And-
strongly physicians.
Strongly
It
physicians.
is strong. It is strong.
I mean, as a percentage, it's a good. I don't know what I would guess that it's like 2/3 physicians.
I would agree. I would agree with
1/3
that.
support.
Yes, I would agree with that.
And I guess more broadly, and maybe you'll get into this, and I apologize, this is my first time at the committee meeting, but do we have goals for either, on the employee workforce side or affiliate or metrics where we kind of look at our, the city population or patient population or other systems that we kind of benchmark to, or is that something
That's a great
that
question. And I think that is our focal point, is always to find opportunities where we can continue diversifying our workforce and working. And I think later on in the presentation, we have Dr. Nicola Davis walk us through some of the work that's happening with Dr. Allen. You will see an effort that we are really looking at diversifying the affiliate workforce, especially physicians. And there's an ongoing effort by our Senior Vice President from Human Resources, Ms. Villanueva, with regard to really trying to look at opportunities where we can diversify our employee workforce as well when their opportunities arise.
Right. Okay. Thank you.
Thank you, Frida. I'm sorry, Dr. Katz, I can skip you. I apologize. Dr. Katz, do you have any question?
Any order is good. No, I just feel very proud looking at our employee workforce and how representative they are of New York City.
Thank you, Dr. Katz. Sally?
Yes, I want to really build on Frida's question I'm looking specifically at the racial, ethnic, and gender breakdown of nurses. Hispanic Latino is 8%, Asian 37, African American 43. And I'm wondering, who is it that would take a deeper dive into the 8% Latinos to look at what factors contributed to it being such a small percentage relative to if you just picked a figure, the representation of the population in New York. But I know there are all kinds of variables that would affect Latino participation. But is that a topic for focus and investigation?
Hi, Sally. It's oh, go ahead,
I
Matilda.
think that, yeah, Dr. Katz really emphasized the fact that I think as a healthcare system, we fare better than other healthcare institutions across the country. I think there is an overall shortage of both African American and Latinos going into medical schools. But, you know, and Natalia can speak to the nursing programs in particular, but I think there is an overall national shortage that I think plays a part in the low numbers of physicians in both, you know, African American, Black, and Latino representation. So Natalia, I cut you off, so I don't want to.
It's okay. So I think there's opportunity, Sally, to focus on recruitment of Hispanic nurses. I think when we look at data across the board, the percentage of Hispanic nurses are lower, but necessarily just when you take a look necessarily here in New York City, I think we can do more. So we're partnering with the Hispanic Nurses Association and also with CUNY that has 14% of Hispanic nurses, and also creating pipelines for those who are Hispanic to become nurses. So I'm actually presenting at 3 p.m. today to talk about the deep dive that we've done in nursing.
Oh, terrific. I look forward to hearing that. Thank you.
You're welcome.
Thank you, Sally. I just, first of all, I want to thank you, Matilda, for this presentation, and I really like how you put the two graphics very nicely, aesthetically pleasing, but very informative. And as Dr. Katz said, it showcases how well the system is doing, comparing and trying to represent the communities that we serve, our patients. And I think this is something that we should be loud into. And I know that in other committees, we have been talking, and I would like to say Dr. Calamia has been a big proponent that some of the great work that we do in different areas, we should be able to disseminate it and communicate it with others so that they get and understand you know, the work that we have done, but also share some of the practices and best practices. So I would say that maybe there is an opportunity here to share, you know, particularly if it is, and I don't believe it's luck that we just happen to be in New York, and that's why we have a diversified workforce, but definitely it's a concerted effort by the leadership in emphasizing the value that diversity brings to our system and the support that it provides to our communities and our patients. So maybe that's something that I could think about it, Matilda. Maybe there are some outlets in which this information can be communicated and disseminated. So that's one point that I would like to make. The second point is to follow up both on Frida and Sally's, and is that, and I know that in the past you have shown the breakdown of the different groups of the workforce, particularly the physicians, the executives, the nurses, and staff, other staff. So I hope that in the future we are able to see this decomposition and comparison with our workforce and our affiliate workforce, and perhaps share with us the programs that they are doing to diversify their ranks. As Natalia is saying, you know, there is definitely outreach program, support for the pipeline that needs to be done, and I believe that all these affiliates will benefit for the increasing the diversity and because of the, again, the communities that they serve. So that's something that I just want to suggest, that maybe in future meetings we have the breakdown by groups, and also have information on what the affiliate are doing to increase diversity in the different groups.
Thank you, Fanny. We'll definitely take that into consideration and have it for you for the next meeting.
Thank you. I think I think you can continue the presentation. Thank you.
So I want to segue now to both Dr. Davis and Natalia Sianas on the Equity and Access Council report out.
Thank you so much. So today I will be presenting with Dr. Davis, Hart, and List. I am the co-chair of the Equity and Access Council, and we're very proud of the work that we've spent during the last 6 months or so, just setting the infrastructure here at New York City Health and Hospitals. The Equity and Access Council provides a strategic direction for the development of programs and initiatives really aimed at eliminating barriers, institutional and structural inequities, and improving the health and well-being of segregated and marginalized communities. Our Equity and Access Council here at New York City Health and Hospitals is comprised of 4 work groups. The first work group is evaluation program efficacy. So we will talk about the efficacy of our data today, and Dr. Hart will present that. Our second work group is around workforce, looking at initiatives to enhance talent diversity. Our third is workplace strategies to improve inclusive practice that I am leading for the system. And last but not least, the fourth work group is equity of care, really looking at strategies to eliminate racial and social inequities. Next slide, please. So our framework. So each project will be driven by equity work groups comprised of approximately 5 to 7 members and guided by 2 project leads to really drive goals and outcomes in each area of focus. The members will be tasked to develop a work plan, to look at pre and post metrics, and as we've talked about as a system, really also assessing milestones within each work group and establishing a timeline for each approved project by our steering committee. The council members will also offer equity work groups guidance and serve as an advisory and oversight capacity for the projects to really champion the work and be accountable for their project/success. Next slide, please. So I'm proud to report that we recently completed recruitment of our work group members. When we launched the Equity and Access Council last year, we sent out a global email and we got a lot of interest. And so we've invited all of those who are interested to come back and to hear more about our council. And we really believe that each work group will comprise of different stakeholders throughout the entire system to really drive projects. And I must say, the meeting that we had last week really entailed a variety of different stakeholders from facilities, nursing, physicians, social work. And so we really think the Equity and Access Council will be diverse in nature by background. Each work group will also establish work group profiles that will entail membership, roles, scope of work, and objectives. And I also want to report that we recently completed a facility survey throughout the entire system to ensure we really understand the current state of diversity, inclusion, and equity work that's happening throughout our system. And so we received good feedback, and we're using that feedback to really drive our projects. And now Dr. Davis will walk you through next steps for our work groups. Dr. Davis, are you on?
Sorry, got it. Thank you. So I'm going to be going through some of our drivers as well as some of our accomplishments. So in terms of some of our equity and access drivers, some of the things that we're really working towards that are going to really drive our work is building a robust data infrastructure that allows us to create disease-specific queries that will incorporate race, ethnicity, language, and other social identity categories so that we will be able to identify health inequities. We're also working to improve the accuracy and the reliability of the way that we collect race, ethnicity, language, sexual orientation, gender identity, and disability demographic values, which will also help in supporting our efforts at both improving healthcare delivery as well as healthcare outcomes. We will also be establishing inclusion groups that will allow staff to connect, collaborate, and support growth for physicians as well as other underrepresented groups. And we'll also be evaluating, and where appropriate, we'll be replacing race-based algorithms that are currently being used in medical care. Next slide, please. So now I'm going to go through some of our accomplishments and milestones. So under the Equity of Care work group, many of our members have been working with the Vaccine Communication Work Group, which has really been focused on how do we communicate effectively to improve vaccination rates. We've also accomplished removing some of the race-based algorithms in medical care. And I'm going to ask Dr. Hart, who's been really leading this work about race-based algorithms, to speak to the accomplishments that we've had there. Next slide, please.
Thank you so much, Nicola, and good morning, everyone. My name is Dr. Lewis Hart. I am a pediatric hospitalist at Kings County, as well as the Director of Equity, Quality, and Safety for the health system. It's a real privilege and a pleasure to be able to present this work to you. So this was an initiative that started out of the Office of Quality and Safety in close partnership and collaboration with the Equity and Access Council, titled Medical Racism. This work was really energized by a New England Journal of Medicine article that was published late last summer titled Hidden in Plain Sight, Reconsidering the Use of Race-Based Clinical Algorithms. The paper, the literature reports around 13 commonly used clinical algorithms that use race as an objective measure in biomedical algorithms or equations that provide different results or different calculations on the basis of subjective race, and thus provide different care based on that input. So in looking at this, we looked at national disparity statistics and realized that kidney disease, unfortunately in our country, the development of end-stage renal disease and the prevalence of chronic kidney disease differs across racial and often social lines. However, when looking at the commonly used equations that provide clinicians with an estimation of a patient's kidney function, which is known as estimated or eGFR, we noticed that, unfortunately, race is considered as an objective input in providing a different answer or a different response to a clinician when assessing a patient's kidney function. We knew that, unfortunately, in the United States of America, African Americans have a 3 times greater rate of developing end-stage kidney disease, and Hispanic or Latino Americans have a 1.5 times greater rate than white Americans in the development of end-stage renal disease. We looked at the current equations that we were utilizing, and we realized that while some did use objective measures like a patient's serum creatinine, which is a protein breakdown product, a patient's age, a patient's biological sex, as well as race. However, when calculating, they use Black and non-Black as the only 2 different races. We thought that this was incongruent with the diversity that exists in the world, especially the diversity that exists in our country, even more especially the diversity that exists in New York City, and didn't believe that anything that was as binary as Black versus non-Black could be providing the most equitable care for our patients. We weren't treating them personally, we were lumping them in social groups and thus unfortunately treating them based on that grouping. For Black Americans, the equations reported a 16 to 21% greater rate of kidney function based on studies that showed in their small underpowered, so I shouldn't say underpowered, in their small studies that around the patients that the reporters identified as Black had higher levels of creatinine and higher levels of GFR or kidney function when measured. So unfortunately, when we looked at this, we saw that the unintended consequence of such an action would be to propagate a biological difference or biological cause for all Black bodies being different than all non-Black bodies, which again just seemed very incongruent with the work we do at health and hospitals and our understanding of personalized medicine and genomics. So when we looked at this, when clinicians are using eGFR to measure someone's kidney function and potentially dictate the care they're delivering, if we are artificially making an at-risk or a sicker potential population, like unfortunately in our country, African Americans, we're artificially making their kidney function look healthier, there might be some benefits and there might be some risks. The benefits of this might be that they would be allowed to stay in studies. You know, there's a certain kidney function to be able to be a subject in a clinical trial. There might be certain medications they'd be allowed to continue if their kidney function was artificially healthier or looked healthier than if they were white. However, when we looked at the downsides, we realized that the way in which we stage kidney disease, this might, if by artificially making numbers look higher, we might delay the referral of African American patients to a specialist like a nephrologist. We might delay their referral to dialysis, and we might also delay their referral to kidney transplantation because, again, we are artificially, but using this equation, making their kidneys appear healthier than if they were white. So the work really started by convening a stakeholder group of our key nephrologists across the organization, known as the Nephrology Work Group, which is led by Dr. John Wagner out of Kings County. And we asked them about the inclusion of such a practice. This was in the late summer of last year, and about what their thoughts of including subjective race which I think we all understand is a social construct that is not a consistent proxy for ancestral or genetic inheritance in their biomedical equations. And at first, they were very hesitant to get to kind of scrapping this practice or even reevaluating the practice, given what a hallmark study this was, led by Levy et al. Around the use of race as a important objective proxy in this biomedical equation. However, after much literature was published this past year around the idea and how this was inconsistent and how this only led to potential fallacious reasoning and really inequitable outcomes for patients, they did reconsider and they allowed me to present to their nephrology work group. The nephrologist on the work group said, "It's interesting that you say that because the patients that we see at health and hospitals unfortunately come to care much later. They come to care much sicker with more advanced kidney disease. And they gave the subjective sense that we already know where they're heading. So why are we artificially making their kidneys look healthier based on very small studies that are not representative of the diversity that we take care of here in New York City?" So really the process started with convening a few of the local leaders, then asking the whole nephrology work group to consider our proposition. And then really once the nephrology work group came to an understanding that they did not believe, as you can see in the key takeaway, they thought that the inclusion of race was fraught with bias and had lasting deleterious implications for Black patients. And for a multitude of social and scientific reasons, the work group felt strongly that the inclusion of subjective race, which is a social construct, as an objective biological proxy for either creatinine generation, how much creatinine a body makes, or creatinine clearance, how quickly kidneys clear creatinine, in a biomedical environment did not meet the scientific rigor required at health and hospitals of our diagnostic screening tools. So this was a very pioneering and landmark stance on this. There were very few institutions that were doing this at the time. I think we were the third or the fourth to do it at that time. Now there are around 15 large institutions, but out of the multitude of institutions that still exist in our country, we're still in the minority and still actually pioneering this work in terms of getting rid of this. Going from the nephrology work group, we then realized that we needed to socialize this process very heavily. And in one of the most democratic processes, I don't think I've been a part of any initiative that has been so well socialized around clinical councils, leading with the Internal Medicine Council, the ICU Council, the Women's Health Council, Quality and Safety Leadership, the Medical Professional Affairs, Equity and Access Council, Clinical Lab Council, our CMO Council, all going around making sure we were educating people on the use of this practice and ensuring that people understood the limitations and the shortcomings of using race and treating our patients differently based on their race in biomedical equations. So this was our first kind of our toes into the water in terms of looking at clinical race-based algorithms. And what we did is we ended up replacing the equation with a race-blind equation. We are aware that there are limitations of this equation, and there is new practice in the world of nephrology around a different equation that is much more costly. I should say a different test, testing for a different protein as a filtered product in the blood. It's much more expensive. It's not readily used. I think at health and hospitals, it was ordered less than 200 times in a 6-month period when looking back at, whereas EGFR was ordered close to 250,000 times in a 6-month period look back. So we know that that is the future of nephrology, but it is a little bit early in terms of cystatin P, and it is a little early in terms of the measurement of that. But we do realize that our current practice of using a race-blind approach has the only limitations of, it wasn't validated in this group. But we felt very strongly that continuing to propagate the idea that there are biologically different causes in social groups on large scale at a universal level was inappropriate and caused more harm than good. So we will continue to look at, unfortunately, in healthcare, and this is well documented in the literature, as patients' kidney function deteriorates, clinicians oftentimes don't update the problem list and don't update and don't reclassify the severity of kidney disease. So it is hard to objectively measure how patients are being treated in the new process. But we will continue to educate our clinicians on this, educate them on the limitations of what EGFR does. It is not supposed to be a once and done test, as creatinine and GFR is not in steady state. It is fluctuating throughout the day and throughout the week. So this is something that is supposed to be used to trend over time. So we will be continuing to educate not only the nephrologists will continue with the internal medicine doctors, but us as an institution around the use of race in clinical algorithms. And this was our first really forte into the water, talking about race-based kidney function testing. So finally, Epic and our partners at Northwell and Cerner were able to remove race or the 2 racialized results and now just process 1 result, which would be the result that all non-Black bodies would get. And that's the single result that all patients will receive going forward in our health system. any questions about this this topic? I know I have another one that I'm going to be presenting on a second clinical algorithm. But just before we take, I wanted to see if anybody had a question on this.
Any questions? Thank you, Dr. Hart. Any questions? I just have a quick question about this. You mentioned other systems. So they are also have removed this value, this kind of approach when they are diagnosing patients?
Yes, I'm part of a collaborative that works across institutions, mostly at academic medical centers, but a few community hospitals as well. And our last count of all of the group's representation is that we had around 15 large health systems, from academic institutions to, again, a couple community health centers that have removed this practice. We know there are more out there, but we are still in the minority in doing this work.
Thank you.
Annie, I have some questions that, I mean, I can wait, Dr. Hart, until after you're done with the other one, because they're probably more broad in the work you're doing, which frankly I find amazing. Like, I think this is really, I don't know a lot about it, but you know, this is clearly groundbreaking. And one of the questions is, how do we get that beyond the 15 other health systems and sort of, you know, get the work that you're doing here more into the broader dialogue and practice. And the other is, and I think you addressed this, and I might have missed it, that are we able to track how this shift in removing racial, inputs into the algorithm, how does that affect the treatment and the outcomes and better equity in care? Is that something that we're able to do, or do you have things put in place to do that?
Yeah, I mean, it's a great question that you asked there. I think that the ultimate process or even outcome measure of not utilizing race-based EGFR will be the utilization of the newer equations that use a different biomarker for kidney filtration, which have been well validated across racial groups as a universal constant. So I think, given the fact that we only used that test, I think it was 118 times in a 6-month period look back, compared to the 248,000 times we had used EGFR, which just comes on the very commonly ordered basic metabolic panel that we all order on our patients. So I think, obviously, that's the trend that we're getting to. It's just a very cost prohibitively expensive test right now. So if we were to do it on scale, it would be, again, cost prohibitive. But I think that is the ultimate, because this is a workaround, but this is not probably the most ultimate, final answer in terms of how best to measure our patient's kidney function. It will be the biomarkers that don't require a race-based stratification or a race-based coefficient. In terms of measuring differential care that they will receive now that their kidney function is no longer being measured on a racialized basis, it again is difficult, as the literature supports, just because clinicians don't do, unfortunately, the best job of documenting the care in their electronic medical records in terms of changing the actual disease severity in the problem list. So it's something I'm working with the nephrologist on in the nephrology work group on what are the best ways to measure differences, but this keeps coming up in conversation as a limitation to the practice. These are downstream measures. These will not affect the development of kidney disease. It might cause earlier referral, which might mitigate. But again, like we know, so much of our inequities in healthcare happen before the four walls of the hospital. We just wanted to ensure that we weren't perpetuating them or continuing to allow unfortunate eugenic practice of treating biological bodies different on the basis of race. But it is a very good question and something we're continuing to look into. But this is an issue that many health systems, every health system that I've talked to that's done this, are looking into. We are looking at, since we don't do transplantation here, we are looking at dialysis numbers and looking at racial demographics and to see if that changes at all. But it's a very good question.
Lou, I think you're underselling the value of the education that you're doing on getting people to refer appropriately when someone might need a transplant or when someone might need an intensification of their medication, right? Because part of the problem, which exists more on the primary care side before they get to the nephrologist, is using the flawed race-based measures. A primary care doctor is going to say, oh, this person doesn't need a referral yet for transplant, or they don't need a referral to the nephrologist because their estimated renal function using the flawed measure looks okay. I'll wait a little longer. While, educating people on why not to use that, I think will affect the ultimate referral of people for transplantation and for intensification of use of ACE inhibitors and other. Dialysis is, as you know, more a question of the whole field is not sure when is the best time to start dialysis with, early dialysis camps and late dialysis camps. But transplants obviously tremendously improve people's quality of life. And the use of ACE inhibitors and other medications really can slow the progression of some forms of renal disease. So I see that as two of the big victories that your work has.
Thank you
so much.
I want to echo what Mitch said, and Lou, Dr. Hart, I'm most impressed with the work, also in terms of how you're trying to change some norms that are in place that, whether they were intended or unintended, are difficult to change nonetheless, and it's highly technical work. So congratulations, and I'm glad that you're playing that leadership role not only for H&H, but across the nation. Thank you.
Thank you, sir.
Thank you, Dr. Hart. So you're going to cover the next one?
Yes, please. So this was our next clinical target, and this is around the counseling that obstetricians give their pregnant patients around whether to pursue a vaginal birth or a C-section for the second delivery. So often, and just for the non-clinicians in the room, when a woman is pregnant for the second time after having an earlier C-section delivery, whether that was emergent or whether that was planned, they might be at an increased risk for a dangerous delivery in terms of, since there is an incision that has now been repaired on the uterus from the primary delivery, there's an increased risk for things like uterine rupture, which can be very deleterious and carry a lot of morbidity and mortality for the woman and for the birthing baby. So there are clinical tools that obstetricians have developed over time and calculators to help potentially guide an obstetrician and a patient's decision on whether to pursue a vaginal birth after an earlier C-section, also known as a TOLAC or a trial of labor after C-section, or whether to proceed right to C-section for what is thought to be a potentially safer means of delivery in a patient who might be higher risk for a bad outcome during that labor. So when looking at these clinical equations, these three major clinical equations came to the surface, and this was also reported in the New England Journal of article that described the 13 clinical algorithms. So these were formulated in the late 2000s, and they include risk factors such as a mother's BMI, such as a mother's age, her clinical history of how many successful or difficult the labors she had prior, but also includes Black race or Hispanic ethnicity as also clinical inputs that would then change the likelihood or decrease the likelihood or change the likelihood of a woman being successful in her vaginal birth after C-section. So for Black women, it actually decreases the estimated success of having a vaginal birth by 67%, and for Hispanic women, decreases the likelihood by 68%. We asked where this actually came from, and this was in retrospective analysis of data, looking at which women had successful vaginal births after C-section versus which didn't, and thus they noticed differences across racial ethnic lines and estimate or hypothesize that this might be valuable to include in screening algorithms because maybe history will repeat itself and populations will continue to have the same outcomes. So the unintended consequence of this is that it actually normalizes pathology, as opposed to saying maybe women who come from different socioeconomic backgrounds and have different access to prenatal care, different access to clean water, healthy foods, clean air, have different outcomes. As opposed to saying that's pathology, we should potentially intervene earlier on. We normalize that pathology and we say it's normal for Black and brown women to have different outcomes around delivery. So let's just risk adjust that away and let's offer them different levels of care downstream at the tail end as opposed to going upstream. And again, I think the unintended consequence of this again is to perpetuate that Black and Hispanic women's bodies or the reproductive organs are fundamentally different than a normal body or a non-Black or Hispanic body, and thus reinforces the false idea that race is itself the biological proxy, not things such as racism or classism, the things that we've all allowed as a society to flourish, and the things that are most likely driving these differential outcomes that exist across racial ethnic groups. We know that Black women in our country have, I think it was recently published, anywhere from 3 to 6 times greater risk of dying during delivery than white Americans. So when looking at this, we realized that not only can bias determine, the levels of care that providers give, but that the actual equations, the actual structures of our healthcare system are also potentially adding to the deleterious outcomes and are potentially perpetuating the differential care that we provide our patients. Again, by normalizing pathology, we now potentially would counsel our patients differently on the basis of their race, regardless of their socioeconomic class, regardless of other potential more important socio-demographic factors, but just looking at someone's race as a proxy that's supposed to represent everyone and their body of work and their lived experience. We know very commonly that in statistical analysis we can risk adjust away things, but in life you can't risk adjust away your lived experience of discrimination, of inequities of care. So again, for very similar reasons, we went through the same kind of thought experiment and practice where we convened leaders on the Women's Health Council, and we brought to them this equation as something that was very important and something that needed to have awareness raised on, and to ensure that we weren't continuing to use such a practice in our health system, given the demographic of the patients that we take care of being a majority of Black and brown women that we actually deliver their babies here in New York City. So we were very proud when we partnered with the chairs of the Women's Health Council that they said we actually had this thought experiment in late 2000s, I should say early 2010s, around whether we should be using such a practice. And they thought that it was actually flawed in its intent and inherently. So they actually they had decided to not include this practice as something either in the EMR when we did actually integrate Epic across the network, and actually never taught it within any of their grand rounds. They never taught it to their trainees. This was something they were very proud of the fact that they never wanted to use here at health and hospitals. So for those same reasons, they felt that this, the inclusion of race in this biomedical equation, acting as a biological proxy and not the subjective social construct that it is, did not meet the scientific rigor at health and hospitals. So we were actually very proud, and so was the Women's Health Council, of continuing to reinforce and really emphasize the deferral of such a use of such a unfortunately race-based or racist practice. And so we wanted to take a deeper look into the numbers to see, like, since we don't use this practice, how do we actually compare to the state and to the rest of the nation? Interestingly enough, and there could be some potential difference in reasons, and this is in the last line under the plans for further action. This is evidenced by our cesarean section rate below the New York State average. We, on average, about 19% of our pregnant mothers deliver via cesarean section, compared to the state's average of around 23%. We also were like, okay, but potentially there are different financial incentives around why we would not want to do a cesarean section compared to a different system. So let's actually look at the rate of how many actually have successful vaginal births after C-section, which is a truer marker of the counseling that they received prior to delivery. And we actually saw that our VBAC rates were actually greater than the New York State average by a large amount, by almost 50%. We had a rate of around 19% versus the state's average of 13.3%. So this really reinvigorated us and made us very proud around our continued use, and really recommitted us to using the most empirically relevant data, such as those objective measures. We know that unfortunately race in our country does matter and does oftentimes can predict things, though inconsistently. So it's not like we were throwing the baby out with the bathwater and are not going to be considerate of this, but we want to tailor and personalize the care that we deliver to our patients, and ensuring that we are taking those unique social histories, that we are understanding the social impediments of health that our patients and all patients experience at various levels, and really starting to tailor the care based on those, not on a biological, not on some kind of universal imperative of race, and really just kind of using a blanketed, binary approach. So this was another way that we were able to really double down on this practice, continuing to educate our providers and trying to work with the American College of Obstetricians and Gynecologists around finding new clinical equations that would better predict a woman's ability to be successful in having a vaginal birth, which can oftentimes be a safer way of delivering a baby.
Okay, thank you, Dr. Hart. I don't know, Dr. If we have other part of the presentation?
Yes, we do have a few more slides.
Okay.
So I just wanted to thank Dr. Hart for that. This is really tremendous work that we've been able to collaborate and work with. And we've just had such great support from across the system, from our clinical laboratories in terms of eliminating race-based GFR, as well as all of the clinical council. So it's really been a great collaborative effort across the system. So thank you so much, Dr. Hart. So we're just gonna have a couple more slides that just speak to the continued work in some of our other pillars. So in terms of workforce diversity, we've had some accomplishments there as well. We had a really successful screening of a movie called Black Men in White Coats, which is a documentary that focused on the devastating and disproportionately low rates of Black male physicians in the US. And in this screening, we had about 1,000 community members sign up for the screening, as well as we had a panel discussion, which had about 200 community members involved in the panel discussion. And it was a really robust, rich discussion led by 3 of our Black physicians, including Dr. Hart, Black male physicians. So that was fantastic. We also have our Physician Diversity Initiative, which is really aimed at improving the diversity of our physician workforce. And these efforts really involve a strategic alliance with our affiliate organizations, which we've been encouraging through our contracting process to really build a sustainable plan for recruitment and retention of a provider workforce that will better reflect the patient population at our hospitals. Next slide, please. In terms of our diversity by numbers, we know that this was a survey that was done by Modern Healthcare, which showed that for health and hospitals, we had about 46% of our senior management that were ethnic or racial minority groups, which was higher than most of the other hospital systems and something really for us to be very proud of. Next slide, please. But we know that there is still work to do. Even though we might be better than many of our systems, we know that there's still room for improvement. And as we can see here, when we look at all leadership, when you go from first line management up to higher executive levels, there are lower rates of African Americans, Asians, as well as Hispanics. So, but specifically more lower rates of African Americans. So there's work to do there for improvement. Next slide, please. When we look at gender and all leadership, we do very well, and we do have women represented at all levels of our leadership. Next slide, please. So just a few remaining accomplishments. So for our inclusion work group, we have started to establish some inclusion work groups. We've started with a Black female physician work group, which will have its first meeting this month. And in our evaluation work group, we have been working on convening a multidisciplinary data team to really streamline how we collect the race, ethnicity, and language data, as well as the SOGI data, how it's collected across the system, and how it will be analyzed and used across the system. And so that is really critical work that is ongoing as well. Next slide, please. So our next steps are really convening the equity work groups. And as Natalia said, we had a really great meeting bringing together many members across the system last week who all want to participate in our various work groups. We will be working on developing our work plans with specific timelines, as well as really doing a lot of thinking about what each metric will be for each work group and thinking about those success metrics. And I believe that's it. Any questions?
Thank you, Dr. Davis, for a wonderful presentation. Again, thank you to Dr. Hart and of course, Matilde for wonderful presentation. I would like to go over the committee members if they have any question about either the part that Dr. Hart presented, the last part, or Dr. Davis. Jose, any questions?
No, just to commend the whole team, Dr. Davis, Dr. Cineas, Dr. Hart, Dr. List, and so on, for all the work on, and Matilde, all for putting this together. I mean, you've done a lot in a very short period of time where there's a lot of things going on in the background, and it's just very impressive. And I know that you'll get a lot of interest in this. And I just want you to know that you have full support from the board on this. We often talk about issues like this, and we're very, very glad that we have a great team looking at them. So I just wanted to say that. Thank you.
Thank you, Jose. Dr. Katz?
No further questions. Thank you.
Thank you, Dr. Katz. Frida?
I just want to echo what Jose said. I think this work is really important, and I'm really very impressed at all that you guys have done already, and the focus areas are really on point and broad, and so thank you. And I don't have, in the interest of time, lots of questions, but I'm sure as the work develops, we'll be hearing more. And so I look forward to that very much. Thank you.
Thank you, Frida. Sally?
Just, I think I'm especially awed by the work done on the kidney disease and the C-section study, because they impact our patients so much. So just kudos on that as well as the entire presentation. Thank you.
Thank you, Sally. Again, I would like to echo what all the colleagues in the committee has mentioned. Great job. We could not have asked for a better team to really be advocating, looking reflectively of our actions, our processes, and how we can always challenge ourselves to really identify how we are able to look at each our patient as an individual and respect them and really bring all our expertise. So I just want to thank all of you. Of course, I would like to thank Dr. Katz for your leadership. I know it takes everybody because you have so many things that you have to worry about it. And most impressive is that even during this year in which we all and the whole nation and the world has been concerned about COVID and being affected by COVID, you have kept the work of looking reflectively our practices and ensuring that we do right for our communities and our patients. So I just want to thank everybody. Again, Matilde, Dr. Cineas, Dr. David, Dr. Hart, and Dr. Katz. Thank you so much. And I just have one question. I'm sorry, I always have a question. If you go back to that chart that shows both our demographics, I always like these charts because it shows kind of a little bit of an interesting phenomenon. No, go through those charts in which it shows the different level from the executive. We see the progression, but it seems that the senior management is an area that maybe close attention may be paid, because we see how from senior management then go to the executive. So I don't know what will explain that kind of difference, but you see how the numbers kind of change from senior to executive. Maybe that will require a little bit of a closer look on what are some of the things that we want. I know that when I was doing research, and this was in the early 90s, we did find that there is a kind of alignment between the executive level and the entry level personnel, but the middle level had a totally different view of the world. So I don't know if there is something at play here similarly, but I think, the way that we evaluate, the way that we kind of recruit, there may be certain things that will be interesting to look at. That's just a comment. But again, I want to thank all the members of the council for the great work. So if there is no other old business that anybody wanted to discuss? Any new business? Well, with that, again, I apologize again for starting so delayed the meeting. We really appreciate your patience, and again, that you were able to share with us the amazing work that you're doing. So without further, if there are no further discussion, this meeting is adjourned. Thank you so much.
Okay.
Yeah, okay, just let me know when to start.
I'm ready now. Okay, 5 seconds.
Okay. Welcome, and thank you for joining us today for the meeting of the New York City Health and Hospital Strategic Planning Committee. Today's meeting is officially called to order. First, I would like to propose a motion to adopt the minutes of the Strategic Planning Committee meeting held on January 11, 2021. Anybody has any questions? Hearing none, I would like to take a collective vote. All in favor?
Yes.
Yes.
Anyone opposed?
From October 1st through December 31st of 2020, which was the kind of part of our comeback from the first surge period and the beginning of our fall winter surge period. So patient volumes declined through that period on the outpatient side, and that did have an impact across a number of measures. The updates now, the measures include the priority measures that committee members suggested and we updated with at the last quarter, and present a number of areas of both improvement and opportunity for further improvement. And then there are significant updates on the federal, state, and city policy sides that Deb Brown will speak to as well. Our other goals for the meeting today are to give a deep dive on our MyChart performance and our next steps on how we're going to be expanding that over the course of the coming year, and then to give a quick update on forthcoming metrics on our social and racial equity base of our strategic planning pyramid. So with that, we'll move to the next slide. And Deb, do you want to take us away?
Sure. Hello, everyone. Nice to see you all. As Matt said, there's a number of significant developments, and the way I've been thinking about these things is that they all sort of cascade, right? Particularly when you're talking about the financial support that we and many other organizations are seeking. As you know, since our last meeting, there was a passage of President Biden's American Rescue Plan. And that though that included no direct funding for hospitals, it did include state and local government funding, which was extremely significant when you think about it in terms of this cascade, federal money going to state, going to city, potentially coming to us. And so that, continues to be good news. And I will say, to the great credit, we have had previous packages that were specifically supportive of hospitals. I think that this one, as you saw, was a little bit broader, a little bit comprehensive, and there is a little bit of a concern, and we'll talk about this in a minute, that there's a consideration or a theory that hospitals are, taken care of. And that's something we continue to sort of push against at all levels. You will see, it's no secret, anyone who reads the paper, anyone who watches the news, despite the thin majority that the Democrats hold, there continues to be significant bipartisan rancor. And you're going to see that, I think, as bills continue to play out, as the Democrats seek to use the reconciliation process. I think this is going to show up in many ways. Obviously, the next big consideration is the infrastructure package that President Biden and many others have been speaking about. It's no surprise, again, for those of you who follow the news, the debate is really what constitutes infrastructure at this point. We, and fortunately, many of our colleagues around the country, individual hospitals as well as associations, are really pushing for the inclusion of hospital needs as a component of infrastructure. And, I don't think that's a word game. I don't think that's something kind of cute or coy. If nothing else, this pandemic has shown us the need for ongoing, strong, resilient building. So that's, very much the focus of current federal advocacy. We are, of course, very fortunate to have Majority Leader Schumer, to have Senator Gillibrand, to have great representation from our House of Representatives folks who represent our hospitals. Sorry, tripped over that one. Especially important is Congresswoman Yvette Clarke, who sits on the Energy and Commerce Committee. We've been working specifically with her office and are very grateful for their support. And I think the last piece on the federal is, as people are taking their seats, as we are seeing, the secretary in place, as we are seeing the secretary's team come into place, we'll have a chance to delve into some of the policy regulatory issues that are, potentially divorced from just payment, I will say, but of course have a significant impact on our work strategically and financially. So these slides, moving down to state, these slides were clearly done a few days ago. We did reach a conclusion on the state budget. There was an email sent out to the board over the weekend. Happily, we and many other hospital colleagues were successful in deterring significant cuts. As I've said previously, the cuts that we were talking about would have had about a $250 million impact on our system. Thanks to, I want to really call out Michelle DeBacco on my team, who lives in Albany, is a creature of Albany in the nicest possible way, and really organized our strategic advocacy starting way back last summer. Early fall was when we first started doing meetings. But we and others were able to push off an across-the-board Medicaid cut, what would have been a very significant elimination of the public ICP or indigent care pool. There was, to a conversation we were having previously, Fenny, there was a continuing capital cut. Fortunately for us, that is of relatively minimal financial hit. I don't want to ever suggest that a few $1 million isn't important, but relative to the $250 million impact that would have come, that was really meaningful. I think what we will see, for those of you who are kind of familiar with the Albany session, is now post-budget, we will be dealing, until, until the end of the session, with a series of programmatic bills, policy bills. So I guess the point is we will continue to be sort of in there fighting. As we do, we are fortunate to have many allies, actually in chambers at the Department of Health, and certainly in the legislature, who are working with us in a number of creative ways. If you could go to the next slide. Thank you. I think the big issues, not surprising, with the city is sort of understanding how this administration will seek to use its resources and its leverage in the remaining months, how this administration is going forward with many of the legacy items that are so important. And we've been very fortunate, H&H has played a significant role, and we are very, very well positioned, I think. Of course, there are going to be budget constraints, so we're sort of in the midst of the city budget process. Went through an initial preliminary budget hearing with Dr. Katz, with John Ulber, with a number of my other colleagues. Went very well, fairly uneventful, which is a good thing. But we are, of course, looking at mayoral changes, many changes in the council, borough presidents, DAs. It's kind of a popping time in terms of New York City elections. And of course, healthcare is extremely important in all of that. So it's, really interesting, and I think important for us to be tracking the health platforms of many of the mayoral candidates, who are largely, sympathetic, supportive of us, understand the need for public hospital system, understand the issues of equity that we work through every day. But that will be, I think, the rounding through the next 6 months, this will be extremely significant for the system. And then just one, last thing to add is we, of course, always work with our communities through our community advisory boards, through the many, advocates and champions we have in the community. I do want to thank both the community advisory boards and our advocates, for the important role that they played in the budget advocacy at the state level. They were instrumental partners, as always. And I think one of the things that we have seen, and this is completely appropriate and positive, is more and more of an outcry or a request from communities for services. And I think you see that in specific geographic pockets. I think you see that in from groups that previously have not felt represented. And so our community work gets kind of bigger, stronger, tougher. I don't mean tougher difficultly, but more muscular, I would hope, as we seek to serve all of these community needs. I'm happy to answer any questions.
Thank you, Deb. I don't know if there is any questions from the committee members.
I just
Sally? Sally, I think you're muted.
about that. Under the state item, you had nursing home focus. State of Albany, were you talking about the governor's issue with the nursing home representations or something different?
Thank you for asking, Sally. Well, what I was really talking about, though it's difficult to divorce them, is there were nursing home provisions in the budget, and what had happened was in the executive budget, the governor's proposed executive budget, there was a whole spate of nursing home provisions and nursing home mandates, and that was another area where not just we, but there was a great deal of industry kind of pushback advocacy to make a more rational sort of plan for the nursing homes. I think that's going to be an issue that we're going to continue to see post-budget. But that was really what I meant. But of course, you know, you are exactly right, Sally. That is completely coupled with what has been going on in the press.
Okay.
Thank you. Frida, you have a question?
It's actually just sort of dovetails on that question Sally had. Congratulations. I mean, this is all good news. But the third bullet, you didn't really touch on either, advancing H&H strengthening. And I wondered if, and this kind of goes to my question of, you know, we sort of dodged a bullet this time, but are these things that are like, were many of these proposals ones that you anticipate will come back up next year, or?
No, it's a great question. And, you know, part of the strengthening is, as I said, because we have been working with chambers, with the Department of Health, and, you know, many arrangements to continue to better serve our populations as well as strengthen us. That was really, you know, that was really what that bullet references. And this actually goes back to last year's budget. We've been doing, you know, work since that time. It's a great question. And yes, many of these things do always continue to recur. You know, I don't know, you know, it's been interesting this year. Of course, the concern initially was, oh my goodness, even before COVID, you know, there was concern about significant, you know, several $billion state deficits, particularly tied to the Medicaid budget. So that was where kind of the first notion of across the board cuts came. Then, of course, you know, COVID came. Then there was this influx of state funding. So, federal funding to the state. So really the issue is going to be, you know, what is kind of a one shot, which will help stabilize the state, and then what we are going to have to worry about going forward. There was, you know, part of the state budget conversation was there are many advocates who are seeking to get rid of the Medicaid global cap entirely. That was not a successful area of advocacy for them. But I think the rethinking of how we structure our Medicaid program, how, you know, the financial inputs to the Medicaid program continue to play out, that's something, you know, that happened well before COVID and is going to continue to play out after COVID. And often that does, you know, manifest in proposed cuts.
Right.
Thank you, Frida. Jose?
No questions, thank you.
Dr. Katz? Any comments?
No, thank you.
Thank you. Matt, back to you.
So, thank you. So I know the board's schedule is crowded this morning, so I will move quickly through this, and I'm happy to answer any questions. I'd say overall we had a number of very positive trends, some negative trends. The key story of this for me is the unpredictability and challenge of in-person visits in a period where we are approaching and moving into a COVID surge. So that's sort of the telling external factor for me. We have, you know, a number of fewer low acuity ED visits, so we have fewer patients leaving without being seen. Had some good results on inpatient care experience, and our MyChart activations have really soared, which is a tremendous success this quarter. Next slide, please. Because of the case mix index we've experienced and the timing of some of the federal relief, we had a very high ratio of revenue to expenses, which is excellent. Continued to make progress on our enterprise resource planning initiative. E-consults have continued to rise, as have our NYC Care enrollment. For some of these where we've dramatically exceeded the target, we tend to update our targets for these at the start of the fiscal year. So that will be our next meeting in July. We will have updated targets on several measures to go over with the board. Next slide, please. Again, on the negative trends, I'd say they all are very tied to the decrease in in-person visits, right? We were at close to 100%, I'd say, in 2019. At our best facilities, we got up close to 85, 90% in person over the summer into the early fall. But with a lack of in-person visits, I think it has been challenging to have those follow-up appointments, and our diabetes control measure, I think, has been slipping and may continue to slip. But we are taking aggressive action on that with pharmacy hires, other extensive outreach to bring people back in and follow up for those visits.
Can I quickly ask a question on that, on one of those? The follow-up appointments kept within 30 days. At all of our QAPI meetings, the hospitals are so far, the numbers are just so low. And I'm wondering whether this is a federal requirement, or if we impose it ourselves, whether we should either decrease the number as a target or see what efforts need to be made to get closer to the target. It's a figure that I don't even remember any of the hospitals coming close to that 66% figure.
Right. I think that is true. We had some success, I'd say back in 2019 is the closest I remember getting up to it. It's a kind of well-endorsed measure. The 66% threshold may be too difficult for us. I think we can revisit that with our performance improvement and quality assurance teams. But it is as a measure itself, managed care plans, CMS, the state across the board do look to this one, and I think it can be an important measure for us of how we are succeeding people connected to care. So we'll look at the 66%, but I take your point. It's been a struggle in recent months, definitely.
Well, actually, yeah. Okay, it's fine. Thank you.
Thank you. And just following up on Sally's, and I know that we are very tight with time, and I know practicing what I'm preaching, but this may be a metric that it will be good to show the benchmarking. How other systems that have similar characteristics to us are meeting before any change of the target. Because since, as you're saying, this is a measure that is looked closely by external stakeholders. If one were to consider changing the target, I think it would be good to see what the benchmarking is against similar peers, hospital system.
Absolutely. We will pull that together for the board at our next meeting. Definitely.
Okay. Since we already, Sally and I asked questions, Frida, do you have any questions?
Just a couple. If we go back to the patient care revenue as a percent of expense, I like the positive trends. I just want to, and I think you might have said this, so the 72.6 is largely due to, say, this includes the CARES revenue, right, as part of in the revenue number, and then obviously we had a higher case mix index, et cetera. But that trend is sort of an anomaly? Would you say that, Matt, or?
I think it has been going up quarter over quarter really for the last 2 years. We have not seen a jump like this at any point in that time, which is, I think, driven by those one-time factors.
Okay.
But overall, it is our most global measure of our financial performance. And the CARES Act funding, I think, was we try not to include supplemental Medicaid or other things not tied to actual patient care experience. The CARES Act funding, of course, was tied to the sheer volume of COVID patients we had, and so it was included in here. But
Matt, aren't our expenses also artificially high during this period? Actually in the second wave, because we weren't able to draw nursing from other places in the country, we really had to pay a premium on the nurse registry in order to have ample staffing. So the expense part is also an anomaly. So it may be that we come out okay.
Right.
Our expenses are going to our expenses are going to drop once we're through this next wave.
Yeah, right. So it may be masking a lot of the other improvements, Mitch, that you're referring to, right? Because both things are elevated, right? And there was one other question I had, that is, do you know if this revenue, patient care revenue, includes the NYC Care dollars, or it does not?
It does, yes.
It does,
yes.
okay. And then on the next slide, on the negative trends, on the post-acute care, all-cause hospitalization, that's a new measure. Do we have a target for that?
I will have to check on our board.
So the rate's going up from last quarter, but I didn't know what our target was.
Let me get back to you on that one,
Okay.
Frida, I apologize. Yeah, I don't believe they've set a target for it yet, but we'll certainly have one at the next meeting.
Right.
Will it be possible to have it? Yeah, okay. Before we submit it to the board, so it would be. You think that will be possible for this month's board meeting?
We can certainly speak to Maureen and the team about it. I think they may have been looking to baseline it as in their initial submissions, but happy to work with them on what their target should be and try to include it before it's at the full board meeting.
Okay, thank you. Frida, any other questions?
No, it was just sort of talking around that, but I think maybe we'll wait till we have more data and information on that and about what's going on there. But
thank you, Frida. Jose?
Thanks.
Okay, Dr. Katz, any comments?
No, I'm wondering if that's affected by COVID. Right, because when we have, right, I mean, nursing homes where you're talking Q1, and nursing homes, that was the period of time when so many people got sick in nursing homes and they would have gone to the hospital.
I think it is tied actually to one kind of cluster of admissions in November, actually, that drove this particular one.
I see, okay.
Yeah.
Okay.
All right.
Thank you.
We have one more slide of negative trends just to look at. Again, I think tied to the in-person visit percentage. The percent of our uninsured patients who were counseled and enrolled in insurance coverage, NYC Care, or other financial assistance did drop. I think the number of our in-person counselors who can talk to people, is challenged by people having more televisits and things, but we are hoping to see that bounce back. The percent of MetroPlus's spending at health and hospitals dipped quarter over quarter. We did have that spike, I think, as the percentage of MetroPlus's other private contracted partners dipped over the prior quarter, which was the summer. And then I think rose back up for them in the fall. And of course, the ratio of our expenses to theirs drives that number. And similarly, I think AR days and unique primary care patients were clearly affected by in-person visits and the ease of follow-up. We will have an update on primary care patients seen at the next board meeting. There's been a slight look at change at the methodology there just to make sure we are not capturing anybody with coming in for just a COVID test in a primary care clinic. So Dr. Long and the team will speak to that at the July meeting as we update it and give you quarter over quarter trends over the past several quarters.
Beyond
that,
can I ask a quick question?
Yes, Sally.
I promise it'll be fast. This percentage of uninsured patients confuses me a little bit. Maybe you can help me. So uninsured patients that were enrolled declined, but this was despite the inclusion of New York City Care insured patients?
Right. So in the prior quarter, 61.4% of the patients who came in without insurance or NYC Care ended up enrolled in one or the other. In the fall quarter, a smaller percentage of the patients who came in uninsured left our care insured or in NYC Care. So I
I
think
just wonder how we still have so many, a significant number of uninsured patients that aren't eligible for New York Cares or one of the managed healthcare plans. I mean, who
Right.
would they be?
I think it is typically people who, for whatever reason, we either are not able to spend the time with to counsel them on their eligibility, or who refuse to have that discussion. So they should be eligible. Everybody should be eligible for one or the other, right? So the goal here, theoretically, we could get to 100%.
Right.
It's more a measure of our workflow, our ability to make sure those folks get the counseling that we would like them to have to make sure they're enrolled in what they're eligible for. So that's what it comes down to.
There's a little bit of outside New York City, right? So especially the FQHCs by mandate, like the ones in the Upper Bronx have to accept people from Westchester. So that would be one group. There are also people who have private insurance who, for whatever reason, don't wish to disclose that. And we try as hard as we can, but people have various reasons for wanting their insurance companies to not know that they have certain conditions. And so that's a second common reason that I think people you'd think, well, they'd either fit in the insurance or they'd fit in the group, they won't give you the interview because they don't want to admit that they have another form of insurance.
I see. Okay, thank you.
Matt, just on that point, there's I think what I'm hearing is it's a little bit due to not being able to screen the patients, but I thought that it says here screening rates are approaching or exceeding the target, which leads me to believe that we're talking to them, but we're not getting them enrolled. Is that?
I think that is true, right? And I think the ability to complete the enrollments over the phone, right, for people who are having telephone and video visits is a challenge. And then I think so that kind of completion and actual enrollment is the barrier.
I see. Okay.
Okay, Matt, yes,
yes, sir. We have two other, again, new measures that are basically a steady trend. Our post-acute accounts receivable days remain relatively steady, and then we have our new measure of total wellness encounters that we have just begun counting on and collecting. We'll have a trend for you at our next quarterly meeting.
Matt, following up on Frida's comments earlier, maybe it would be good to find out if there is a target for the wellness, since that's another new measure that doesn't have target, but there was a new measure that did have target. So if you are able to find that, that would be great, and have it for the school board meeting. Thank you.
Okay. Excellent. On our COVID measures, again, I think a good reflection of how involved and effective our system has been in responding to the crisis. During this period, we did over 1 million COVID tests. Our post-acute infection rate was very strong, certainly compared to the national average and the state average. And then, a major role in vaccine administration. During this period, the percent of occupied beds was quite low. It inched up as the winter surge came in, but again, always remaining below the state's 85% threshold around our system.
I'm sorry, I had just a quick question.
That's okay.
Go ahead.
Ted Long just reported that they were responsible for about 50,000 vaccines. Is that enrolled into our figures, whether it's the 100,000 or 200,000?
Not necessarily, Sally, because what the canvassers will do is connect people to the soonest appointment.
Right.
They basically, so it wouldn't necessarily have to be with us. Right, it could be a DOH-MH site or a state site.
Oh, okay.
Okay, and then Dr. Davis was going to walk us through some of the Equity and Access Council's work and how we are considering adding new metrics to look at our social and racial equity base of our strategic pyramid.
Matt and Dr. Davis, can
Yes,
you
sir.
hold 1 second? Let me just check because we are moving from one area to another just to make sure that there's no other questions. Sally, do you have any other questions about the metrics?
No, thank you, Fanny.
Frida, do you have any question about the metrics? Jose?
No, thank you.
No, and Dr. Katz?
Nope.
No, okay. Dr. Davis, please. Sorry for the interruption.
Sure, no problem. So very briefly, because I know we are pressed for time, but the Equity and Access Council, the goal of the council is to provide strategic direction for the development of programs and initiatives aimed at eliminating barriers, institutional and structural inequities, and to improve the health and well-being of our vulnerable and marginalized communities. So our work is organized into 4 work groups. The Evaluation and Monitoring Work Group uses data to measure our program efficacy. The Workforce Work Group is using initiatives to enhance talent diversity. Our Workplace Work Group is looking at strategies to promote inclusive practice, and the Equity of Care Work Group, which are strategies to eliminate racial and social inequities. Next slide, please. So in thinking about our metrics, we've been thinking about what we'll need to really drive the work forward. And some of our considerations include building a robust data infrastructure, which will allow us to create disease-specific queries that are going to incorporate race, ethnicity, and other social identity categories. And this will enable us to identify disparities. We'll also be establishing inclusion groups that will allow for staff to connect and collaborate, as well as supporting career growth for physicians from underrepresented groups. We'll be evaluating, and where appropriate, we'll be replacing race-based algorithms in our clinical care, as well as we'll be improving the accuracy and the reliability of the collection of race, ethnicity, language, sexual orientation, gender identity, and other disability demographic values in supporting our system's ongoing efforts to improve both the healthcare delivery and the healthcare outcomes. So these are all areas that we will be considering in thinking about our metrics. Any questions?
Thank you, Dr. Davis. Sally, any comments about the potential metrics that will be used by Equity and Access?
No, thank you, Fanny.
Frida? Jose?
Thank you.
Dr. Katz?
Nope.
My only comment, Dr. Davis, is that, since your council is looking overall at health and hospital system, to consider metrics have to do both with the contracting, like MWBE, as well as the personnel demographics, as we have seen in the Equity, Diversity, and Inclusion Committee. So that would be just a suggestion. Thank you, Dr.
Great.
Davis.
Thank you.
Great, and next we'll have an overview of our MyChart performance, which has really exceeded all expectations, and we're going to build upon quite a bit over the next year. So Jeremy, Becca, you want to take us away?
Yes, good afternoon, everyone. My name is Jeremy Siegel. I'm the Chief Wellness Officer for the system, supporting the workforce wellness, care experience, and system performance improvement portfolios. On behalf of the core MyChart planning team, it is an honor and a privilege to present upon our MyChart successes, as well as our look ahead for you. As many of you know, MyChart is a patient engagement and tool for us to really make an easy, seamless experience for our patient populations that we serve to connect to our system. It aligns to all 5 of our strategic pillars and really is a pipeline to patient growth, but more importantly, enhance population health outcomes. I'd love to introduce my colleague, Becca McLean, who's going to provide some overview in terms of our patient portal metrics and a look ahead as to accomplishments as well as projects that we are in progress with. And we'll speak toward the end of this presentation upon how we are aligning our mission, vision, and values to enhancing MyChart. Becca?
Great, thanks so much, Jeremy. Hello, everyone. I'm Becca McLean. I work out of the Office of Ambulatory Care and Population Health on MyChart. So we all know that MyChart is our patient portal at New York City Health and Hospitals, and this gives our patients access to their health information 24/7. And using MyChart, patients can view their test results, request and view appointments, track their medications, send messages to their doctor's office, pay their bills, and more. So to track our MyChart engagement and activation success throughout 2020, the MyChart Steering Committee established 3 core metrics. So this is the percentage of patients that are active in MyChart, the total number of MyChart users, and the number of times users of MyChart log into their accounts. So here's just a snapshot of our overall data for 2020, as well as where we stood as of late March at the end of Q1 for 2021. So hoping to gain a more comprehensive understanding of how our patients are using MyChart, the MyChart Executive Steering Committee has also added additional metrics to track in 2021. Reporting components are currently being built to track these metrics and embed them into our reporting processes to inform our system-wide initiatives, as well as our site-specific projects. You can just see them listed there at the bottom of the screen. Next slide. Great, so I'm also excited for the opportunity to share a snapshot of our MyChart projects completed in 2020 around staff and provider education, as well as patient engagement. So a few of our most impactful 2020 projects include working with our Office of Diversity and Inclusion colleagues to ensure that we have patient-facing MyChart guides for our patients that are translated into our top 13 languages, and also operationalizing MyChart video visits across our system during the ongoing pandemic, and establishing a dedicated MyChart helpline for patients to use if they have questions about MyChart or if they need a little bit of tech support. And on the right hand of the slide, I've just listed a few of our upcoming and in-progress projects to give folks a sense of what we're currently working on. And I'm just going to highlight a few here for the group today. So we're going to be launching our facility-based MyChart steering committees to assist in improvement efforts, working to identify and implement performance and improvement projects with the support of the MyChart planning team. And those are going to be kicking off on May 1st, which is very exciting. And then we're also going to be, looking to continue to leverage MyChart to directly link our patients to virtual express care should they need. That's right within the app now, which is nice and convenient. And of course, using MyChart surveys to address our VBP care gaps, our Gotham adolescent engagement campaign, and updating our sites and patient spaces with new MyChart engagement posters as well. So that's just a few that I wanted to highlight for the group today, and I'll just kick it back over to Jeremy to add any additional thoughts or comments.
Thank you, Becca. Becca honestly is our internal subject matter expert, and it is truly a pleasure working alongside of you. So as we want to continue to improve upon MyChart activations, as well as usability for both patients, but also the workforce, we created 2 separate work groups. We have a patient engagement work group made up of a variety of different departments and disciplines at every touch point that a patient touches that might be able to engage in MyChart. And we also did the same thing for our workforce engagement work group made up of different providers of care, various levels of the organization to really help us understand how we can optimize usability on their end as well. In addition to that, what we wanted to do is revamp and restructure the enterprise-wide MyChart Executive Steering Committee made up of high officials across our system, as well as various department heads and disciplines, so that we make sure that we have a unified and uniform approach and strategy for the system. In addition, you heard me mention the core MyChart Planning Committee. That's a way for us to be the conduit to make sure that all communication is not only robust, but that we're all on the same page in terms of our goals, missions, as well as initiatives. As well as we are now launching, as you heard, in the coming weeks, site-specific committees that are made up at the site level, making sure that our care experience officers, as well as other stakeholders and champions of MyChart can work together. The great thing about MyChart is that it has incredible data that we can drill down to a service, to department, and then to a provider. So it provides us a lot of opportunity to really do some PDSA cycles and improvement efforts to really engage our patients better with MyChart and to really make sure that it's an efficient and effective tool for all.
Thank you so much, Jeremy. Any questions from board members?
Sally? Sally, you are
Sally, I think you're sorry.
The percentage of patients active in MyCharts, these are individual patients, went up from 875,000 at the end of 2020 to 3 million at the end of the first quarter of 2021. Am I reading that right?
Correct.
That's amazing.
Yeah.
And
It's
amazing. Does this include Gotham sites, H&H, our long-term care facilities, everything?
Everything. That's at the system, whole system span. Yeah.
Fantastic.
Thank you.
That's it.
Thank you. Frida, any question?
Yes, on that, it is really amazing, and I think it's transforming, the way we do things. So it's terrific. I had a question on the averages, and this sort of gets to the point, a little bit the point of what Sally was asking is whether we can track that some of those activations are actually perhaps because of, say, COVID or vaccine, or maybe someone who came to our system but won't be staying in our system, and so. One, if you have a sense of that, it'd be great to hear, but also on the averages, is this just a straight average, like the number of users divided by the number of accesses, or do we actually track the average, an actual user and how many times they use MyChart? Do you know what I mean? The distinction that I'm trying to.
Yeah, so I think to your first question, just kind of looking like, okay, is this huge explosion just from COVID, from COVID test patients, or like how many are truly our patients with a primary care physician in our primary care departments receiving care from us? And I wish I would have included that slide. I can send it along in the appendix for reference, but we did do a drill down into our primary care departments, and it was just astounding. Some of the numbers are actually higher by primary care departments per site. Just a real testament to our staff's willingness to talk to our patients about MyChart, and also our patients' willingness to engage in and use the tool, which is fantastic as well. So we have done drill downs in those numbers to look, for more meaning in the data, to see, what is the context that MyChart is really used in. And again, how can we leverage that to stay connected to our patients, to get them to utilize these tools and feel connected to our care too.
Right. That's
building. Sorry, I was just going to say, building off of what Becca was just talking about, we're creating our own MyChart scorecard that the Executive Steering Committee is going to be seeing on a consistent basis, and we're really drilling down to remove the special pathogens only visits, which would be the COVID testing patients and things like that, and begin to drill down even further in the primary care active patients to see where we have future opportunities.
Great. Yeah, that'd be interesting to see. Thank you.
Jose, any questions about MyChart? No?
No, thank you. Just great work.
Thank you. Thank you.
Great. Well, this is our overall view. As we went through the positive, negative, and steady trends, we will get you those updated targets for the measures without them thus far, and look forward to presenting you and updating on some of the targets in our July meeting. Anything else I can answer or we can discuss with the board before we conclude?
No questions? Any old business that we need to address? Any new business? Hearing no more questions or items of discussion, I would like to adjourn this meeting. Thank you, Matt. Thank you, everybody, for presenting. Dr. Davis, everybody, thank you so much for presenting. Thank you. Bye-bye.
Bye.
Thank you.
She's been at this since 9 a.m.,
I know. Well, we all have been since 9 a.m. I think she has been at this from 7 a.m. We have been at 9 a.m., but I saw email from her before that.
When we're sitting at home.
Yeah, Mr. Nolan is here. Okay.
Yes.
Yeah, we have quorum and we're going to start. David, are you ready for me?
Okay. Yes.
30 seconds?
Okay.
Okay, Penny, we have quorum. After the recording, 5 seconds, we have yourself, Jose, Mr. Nolan, and Sally, and we can start soon right after the recording. Just give us 30 seconds to get it up on YouTube.
Okay. Hi, Bob. How are you?
Hi. How are you today?
Okay. The Bronx is in the house.
I'm here relief from those of you who've been in pain and torture from this morning.
I know. We only have Manhattan represented by Jose, so he's outnumbered.
Fine group.
Okay, we're ready, okay?
Okay.
Okay.
Good morning, welcome, and thank you for joining us today for the meeting of the New York City Health and Hospital Capital Committee. Today's meeting is officially called to order. First, I would like to propose a motion to adopt the minutes of the Capital Committee meeting held on February 8th, 2021. Is there any questions? If there is no question, let me ask, all in favor?
Yes.
Yes.
Anyone opposed? Hearing, the motion is carried. Thank you. Now, we would like to hear from Senior Vice President, Ms. Flaherty, about her report.
Good afternoon, Chair Kurgan and Pinimura. Thank you for allowing us one resolution to get our general construction, job order, contracting requirements, contracts in place. Our OFD department remains engaged in our capital development, facility management, real estate, and housing work. Next month, we will have a robust capital meeting covering all aspects of our office. Our design activity on approximately 40 projects supporting our system with the new bond funding is well underway. We look forward to doing a more robust update on that portfolio of work during our May debriefing. Given that Earth Day happens this month, I wanted to let you know we're excited about our ongoing partnerships with Department of Citywide Services, New York Power Authority, and Con Ed to combat climate change by reducing our energy usage and our carbon footprint. We're excited to be kicking off a number of new energy saving projects system-wide this year, and we received additional funding for 2 energy projects from DCAS that will help us at Harlem and North Central Bronx. We're in the process of initiating those projects for the design phase. And now I'd like to move to the board resolution unless there's any questions from the committee.
Thank you. Any questions? No? Thank you. Ms. Flaherty, please continue to the resolution.
Thank you. This resolution is for authorizing the New York City Health and Hospitals Corp., the system, to execute job order contracts, JOCs, with 3 firms, Ballmer Construction, Inc., BA Global, Inc., and Carefree Improvements, Inc., the contractors that were selected through the system's public bid process to provide general construction services on an as-needed basis at various facilities throughout the system, with each contract to be for a term of 2 years for an amount not to exceed $10 million for each contract, for a total authorized value of $30 million. And now I'll start. So the background here is that we utilize job order contracting, known as JOCs, as construction contracts that we award based on a public competitive bid, and the bidders use a multiplier against an itemized catalog of services that cover both labor and material. The solicitation happens like any normal lump sum bid, and it's identified, and that process follows all of our OP procedures in 100-5. This allows contractors to have an established pricing model for unique specific projects, and tasks are based out of this bid with preset prices. In 2019, there were 3 general contractors awarded under the same model. Their contracts expire in June, and this resolution reflects a new award for new contractors. The proposals related to this work includes the book itself is maintained by Gordian, who helps facilitate the JOCs program, and they update the price book regularly, annually, according to New York City cost construction indices published by Engineering News Record. These contracts are deployed across all facilities, any H&H facility that general construction is needed for, any smaller scale projects and urgent projects where the scope is well defined. It allows us to move quickly into construction. Next slide. This gives you a current overview of the 3 existing vendors that were identified in the winter of 2019 and awarded with contracts executed in June of 2019. Rochelle, Carefree, and Gemco are those 3 general contractors. their multipliers listed, as well as their current capacity of the contracts and work orders issued to date, as well as their MWBE spend across those contracts. Rochelle is an MBE firm and Carefree also is an MBE firm. So those have very high utilizations. Gemco is at 26% utilization. And at the time of those bids, 6 firms participated in those solicitations in the winter of 2019. Next. So for this procurement, public bids were opened on 3 different days, the 24th, 25th, and 26th, as GC1, GC2, and GC3. Each of those contracts distinctly have 2-year terms, and we received bids from 17 discrete firms. GC1, the lowest bidder was Volmar Construction, and their multipliers listed there. 17 bids were submitted. Their max evaluation and passport is satisfactory, and Volmar has been a JOCS contractor for H&H, and so their user rating within our system is 96.5% across 4 facilities that they've worked on 20 projects. The next low bidder was BA Global for GC2. They had the lowest multiplier from 11 bids that were received. They have private references that have been excellent, and they are new to H&H, just recently started a project at Woodhull through another resolution that actually came to this committee a few months back. And but their track record thus far has seen as satisfactory based on the feedback we received from prior users of their services. The third low bidder under the GC3 distinct contract is Carefree Improvements, an MBE firm. Their lowest multiplier is listed. 9 bids were submitted for that. They didn't have recent MOX evaluations. Our in-house user rating for them is 87% across 4 facilities on 6 projects. We've been working closely with Carefree, and their recent performance has improved. They recently are going to be ribbon cutting and ED department at Woodhull Hospital, which was a fast-track project, and we're very happy at their performance there.
I'm sorry. So does this figure include that? The ED?
No, not yet, Sally. That project, that was a smaller, low bit, under $5 million separate procurement that happened in the summer. And so they haven't hit the 1-year evaluation period for us to do the evaluation for them.
Okay.
So the next slide shows you the MWBE utilization plans for each firm. Volmar has a number of firms, both suppliers and performers, service providers, to have a 31% MWBE utilization plan. BA Global actually has their MBE certification pending at SBS currently. And so this utilization plan here indicates their subcontracting plan of 45% for MWBE participants. Should BA Global's MBE certification be approved by SBS, their utilization would become 100%. But today we have it listed at 45% for the reasons I already outlined. And Carefree at MBE also has electric, their subcontracting, and their MWBE utilization plan. They self-perform 60%, so their total is 70% MWBE participation. And finally, this is the resolution language itself that I read at the beginning of this presentation. We're happy to take any questions.
Thank you. Let me go through all the members. Jose, any questions?
No questions. Thank you so much, Christine.
Sally, any question?
I think just the obvious question about Carefree Improvement. I always get concerned about awarding MWBE or MBE contracts and making sure that they're able to perform to the best of their ability. And now we're adding on to it. So what has been the reason for their delays? Do you know?
So, I mean, there hasn't been delays on their recent projects. We have been working closely with Carefree and mentoring and, supporting them and making sure that they succeed at the projects they work on. A user rating overall of 87% still is in the good standing across our system. They're a smaller company, and so we just have to be cognizant of their capacity and capabilities and not try to overload them with more work than they can take on, but also give them opportunities. And so there isn't a project that they're delayed. They're actually met the schedule of the recent project that we hope to do a ribbon cutting this coming spring, summer, based upon kind of the other pieces of completion happening at Woodhull. Does that answer your question, Sally?
Yeah, I mean, I just, again, my only concern is that, as you say, too much good luck can be bad luck. You don't want to overstress them in their capacity, but if you're monitoring that, it's fine.
Yeah, and I think that's why we have these as system-wide contracts. So there's 3 options for a facility to go to. The pricing's already predetermined. This allows a vendor also to say they're a little busy on something else. It also allows us to inform the facility if we're already aware that that vendor's tapped out or busy on other projects. So we'd like to have options for the facility.
Thank you, Christine.
Thank you.
Thank you, Sally. Jose, any question?
No.
Bob, any question?
Yes, can you hear me?
Yes.
Okay, thank you, Christine, for your presentation. It's very extensive and covers as many things as I would think about. I particularly want to thank you for using the H&H user rating, because this has become an issue over the years where a very common question is, well, what is your experience with this particular company within health and hospitals? And so I want to thank you for using that. It means a lot to me because I can see that means that we have experience with these companies. We see the certain percentages that tell us, the rating and evaluation given by H&H. And I want to thank you. I have no questions other than that observation.
Thank you, Bob.
Thank you.
I just have one comment, Christine. I think follow up on Sally's comment is that perhaps there is a way that you can present when you are in kind of making the introduction to this motion at the board meeting to balance both, the rating as well as the action that your team will take to ensure that these vendors deliver for the different facilities, so that you balance those out and try to answer those questions before they are raised. If there is no other questions, I would like to take a vote. Jose?
Yes.
Sally?
Yes.
Bob?
Yes.
And Feniowski also vote yes. So if that, I believe that's the only motion that you have for us, Christine?
Yes, this month.
This you tried. I like Christine. You giving us a up that this is a light month for us. But
clear the decks next month.
any old business we would like to discuss? Any new business? Hearing no further discussions.
Fanny,
Sorry, Sally. Yes.
On the 4 contracts that Carefree got with 6 facilities, could I just get a sense of the total of those contracts, or when you get a chance, Christine?
The total volume,
Sure.
construction volume?
The total dollar amount of the projects they did.
So we'll triple check, but I believe that it ties to the capacity associated with the chart earlier on slide. Sorry, slide 3.
Yeah.
Shows you the number of projects, but we'll round back on that, Sally, just so that we're fully clear, and we'll provide you a breakdown of the projects.
Okay, thank you.
But Christine, wouldn't the amount be 4 million at least up to now? The volume of construction work?
It should be. I don't want to, I need to look at the details. Also, as what came up when we talked about the Woodhull project, that doesn't have its evaluation in yet because the project is underway and it's less than a year. So there could be newer projects that they're just starting that aren't in that 6 because it's underway. So, you know, we're not evaluating every month. We're evaluating, you know, once a year or in tandem with completion, with full completion.
Okay. So if you can get that information to Sally, that would be good so that she are able to understand better.
Sure.
Again, any all business, any new business? No? Again, thank you, both of you, for the patience, and thank you. And with this, I would like to formally adjourn this meeting. Thank you so much.
Okay,
Thank you,
time-
Jose. Thank you, Bob. Thank you, Sally. Bye-bye.
Thank you, everybody. See you soon.